All right. We are, I think, on the live stream. We'll start here in just a moment. We got people joining in, and we'll start in 2 minutes, and we'll start the presentation. Well, everybody, welcome. Those of you who are joining us from our live streams, make sure that you put in the comments as you're joining us. Tell us where you're coming from. We'd love to be checking in with where people are listening. I'm always excited to see people listening from all over the world. So just pop it in the comments. And then, of course, if you have questions for our speakers as we go along, put those in the comments. Okay, let's go back to here. All right, you ready, Rakesh?
Yes.
All right. Hello, everyone. Welcome to the American Society of Regional Anesthesia and Pain Medicine. We are coming to you live from America, 2 different coasts of America, for this World Day of Regional Anesthesia and Pain Medicine. We are so excited to be part of the world community celebrating our specialty, celebrating patient care and pain management for patients. And I know many of you have been listening to recordings and live streams from all over the world all week, participating in events. And this is our contribution from the American Society. My name is Raj Gupta. I'll be one of your hosts today. I'm from Nashville, Tennessee at Vanderbilt University. I'm also on the board of directors for ASRA Pain Medicine. And I'm going to be with you all day today. We've got multiple hours of presentations coming and a whole host of wonderful speakers and topics. So stay tuned, join in, put things in the comments, and contribute to the conversation. And I want to introduce my co-host today, Rakesh Sondekoppam. Rakesh, you want to introduce yourself? Tell us where you're from and what you're up to.
Yeah. Hi, everyone. My name is Rakesh. I'm from the West Coast of the United States. I work at Stanford University. I'm vice chair for Guidelines and Regulatory Committee in ASRA, and I'm excited to be part of this great event of World Day of Regional Anesthesia. It's a huge honor.
Well, we want to start with a very important person and bring her on board. Eleni Moka. Eleni is the president of the European Society of Regional Anesthesia, and this is kind of her brainchild, this World Day of Regional Anesthesia. Eleni, you want to give us a little comment about this special day?
Yes. Many thanks for the very kind introduction to both of you, to both you, Raj and Rakesh. I'm Eleni Moka, yes, the president of ASRA, but above all, your friend, your colleague, because we do the same things all over the world. It is true that this is a kind of my child this day. It's the continuity of the European Day that was taking place in Europe in the past. And I have to admit that altogether we made it a reality. We made a reality to show our purpose, show our vision, our mission to the people, to the community, through collaborative efforts to train, to educate, to make people learn for a better care and a better RA and perioperative pain pathway. Thank you very much to ASRA Pain Medicine for the support. Truly appreciate it, truly remarkable. And we know that we can go together even further in these endeavors.
Thank you so much, Eleni, and thank you for your inspiration and bringing the world community together. I think that we could do so much more when we're working together and expanding the specialty and most importantly, expanding what we can offer to patients. And so we really appreciate your guidance and your inspiration, and and just enthusiasm for this. So we're excited to be part of it today.
One point, if I may say, you know that the activity is endorsed by many organizations, but for us, it was a really positive surprise that the World Health Organization and the Pan American Health Organization supported strongly with strong statements what we do, meaning they finally understood our purpose and our vision. And I think they will focus even further on what we may be missing, the advocacy for our patients through these journeys. Thank you.
Thank you so much. And we're going to get right into our speakers. Eleni, have a wonderful day. I know you've got a lot of welcome addresses to give all over the place. So thank you so much for your time.
Thank you. Thank you. Good luck. Good luck to all.
Right. Bye. Well, that's wonderful. Eleni's been such an inspiration in this. And we want to jump right into our first speaker. We've got so many topics today. Rakesh, you want to introduce the topic, the first category of topics that we're going to be doing today?
So today, the first session, the opening session will be, it's entitled From Technical Skill to System Safety, How Can We Prevent Harm in Regional Anesthesia in the Modern Practice? So safety in regional anesthesia is paramount to our practice, whether from technical problem to image quality or drug dosage. We have to be very meticulous, and also we have to introspect ourselves how we can mitigate or avoid these problems. So this session is aimed at going beyond the dogma on to focus on how modern regional anesthesia fails, but how to look at it from a systems perspective to make it more. So the first topic will be entitled, How Can We Prevent Wrong-Sided Block? The second topic is how to deal with post-operative neurological symptoms when blocks go wrong. And the third topic is even more apt for the current practice because technology can create its own set of risks. So how ultrasound, AI, and all those newer technologies can create an illusion of safety and how to deal with it. With that, I'll give back the stage to Raj.
So our first speaker, Uchenna Uma, is going to be talking on the topic of wrong-sided and wrong-site blocks. Uchenna, I'm just going to let you introduce yourself and start your presentation. I've got your slides up on the screen, and we'll take ourselves off and let you continue the presentation.
Perfect. Raj and Rakesh, thank you guys so much for the opportunity. I really appreciate the time. So I'm Dr. Uchenna Ume. I'm an anesthesiologist at Hospital for Special Surgery, clinical associate professor at Weill Cornell Medicine, and I'll be talking today about prevention and management of wrong-sided and wrong-site blocks. So for the learning objectives, I'll identify the key risk factors for these blocks. I'll describe a robust verification process and how to apply evidence-based prevention strategies. And then we'll discuss some system-level contributors and how to manage and report these blocks appropriately. So wrong-sided blocks are considered, and wrong-side surgery are considered never events, right? The Joint Commission defines wrong-site surgery as an invasive procedure performed on the wrong part of the body, wrong site, or the wrong patient, thus exposing them to more than minimal risk. And this definition encompasses procedures that are done both in the operating room as well as outside of the OR. And as I mentioned, it's considered a never event by the Agency for Healthcare Research and Quality, and also in the UK by the National Health Services Healthcare Safety and Investigation Branch. So it can cause patient harm, loss of trust, and has medical legal implications. And despite all the guidelines and checklists, it still occurs. And then the last thing I wanted to point out is it does have a profound emotional and professional impact on the clinicians who are our second victims. So how do we define wrong-sided block? What do we mean when we say that? So a wrong-side block is defined as the correct procedure on the incorrect side, and a wrong-side block is incorrect anatomical location. And of course, this can occur in perioperative regional anesthesia as well as interventional pain procedures. The incidence varies depending on the institution, but it can be as frequent as 7.5 per 100,000. I used two institutional data in the tables you can see here up on the right side. I first looked at a study that was published at University of Pittsburgh Medical Center, and they looked at their institutional data from 2003 to 2012, and they examined about 70,000 patients who received only unilateral blocks. And in their institution in that time period, over that time period, they had 9 wrong-sided blocks, which gave them an incidence of 1.28 per 10,000 patients. The incidence of wrong site block in their data was highest amongst femoral blocks, and it also differed from the incidence of wrong site surgery, which was higher. They did mention in their paper that all occurrences of wrong site block was after the implementation of their timeout policy. And so they all involved policy violations. The second table below is actually from my institution at HSS. Greg Ligori and a couple of other colleagues published our data from 2003 to 2016. And they looked at the incidence of wrong-sided blocks for all peripheral nerve block types, both upper and lower extremity. And the rate at the institution at that time was 0.5 per 10,000. But they did note that the incidence of wrong-sided blocks decreased from all peripheral nerve block types, both upper and lower extremity, after implementation of the change in policy. So what are some of the risk factors for this procedure? So first, we'll focus on some of the patient and procedural contributors. So I think bilateral symptoms and pathology are very, very important to note. I think the most recent one that we had at HSS a few months ago involved a patient that was supposed to have an adductor canal block on one surgical site, but the surgeon was also supposed to do an injection, a steroid injection on the opposite side. And unfortunately, the block got placed on the side of the injection versus on the side that was supposed to have the total knee replacement. So that definitely plays a role. I think altered mental status and language barriers where the patient is unable to identify what the correct part of the body or where the correct procedure side is. Things like time pressure, emergency cases, complex anatomy position, multiple procedures in one encounter, et cetera, et cetera. So I was reading up about this, and I saw this interesting article in Anesthesiology News in 2021, and they pointed out that, even how we drape our patients for the procedure may contribute, right? As you can see in session B, they had marked out the correct side for the patient for the block. But then after they prepped and draped the patient, their drape actually covers the site that they're working on, their site marking. So that's something to take into consideration. Now let's talk about the second risk factors, human and system factors. So we'll have things like cognitive biases, interruptions and distractions, inadequate handoffs, poor documentation, lack of standardization, and not following your protocol or your checklist. And again, I selected this one case that was published as in RAPM. This was a case that was presented at the 2023 ASRA Spring meeting. And this was from a group in the UK, and they unfortunately had a wrong-sided upper extremity block. And I think this was a nice thing to read, because you could see how they went through what they kind of determined, how did we end up having this wrong-sided block? So their reasoning was a problem. A nerve block was performed on the contralateral sides of planned surgery. Why? We forgot to stop before you block. So they forgot the timeout process. The second reason, we were distracted by the ergonomic setup. A third reason, the ultrasound machine was prepared and ready for the incorrect side. They needed the ultrasound machine for IV access on the opposite side. And then after they placed the IV, they then moved up the arm and placed the block on the incorrect side. So kind of evaluating these processes and reporting them are important. So next I wanted to talk about the Joint Commission, the principles of their universal protocol. So they emphasize that wrong person, wrong site, and wrong procedure surgery can and must be prevented. They're encouraging using multiple complementary strategies, active involvement, use of effective methods of communication among all members of the procedure team. And then lastly, consistent implementation of a standardized protocol. So what's important in our pre-procedure verification checklists? So things that we want to include are a correct patient identification, your correct procedure and site confirmation, valid and specific consent, clear site marking, and overall a multidisciplinary agreement. So timeouts are actually one of the elements of the Joint Commission Universal Protocol for preventing wrong site, wrong procedure, and wrong person surgery. And that has been effective. The Joint Commission has implemented this since July 1st, 2024. And specifically at my institution at HSS, we mandated a timeout process before peripheral nerve blocks in 2003. And then in 2007, we made 2 more changes in our policy to mitigate the risk. And again, this is very similar to the World Health Organization's checklist, which is their 19-point checklist, which they want people to use for any procedure. So that's not limited to anesthesia, specifically it's for all surgical or invasive procedures. So now let's focus on site marking and timeout. What are the steps that you should be taking? So for best practices, you want to mark the site with the patient involved if possible. Obviously, we talked about language barriers and patients might have dementia who may not be able to participate in the process. We also want to use standardized, unambiguous marking. I'll give one example. At one institution that I worked in, the surgeon's initials were NO. And of course, if he puts NO on the site, it might look to like the staff as like, do not block that side. So it's very important that things like that are kind of clarified ahead of time. Perform a block specific timeout and reconfirm patient procedure side and imaging orientation. I did want to talk a little bit about this stop before you go session, which was implemented in the UK in 2021. And the 3 phases of the prep, stop, and block are underlined and in different colors. And the time points at which to hand over and hand back the tray are shown, as well as emphasis that there's a delay to immediate insertion of block after stop moment. So again, as you go along in the when you're in the stop section, if you're not able to complete the stop section to move to the block section, they want you to go back up to the prep section on the top. So additional evidence-based preventions strategies also have standardized checklists, the stop before you block, or some sort of verification process. Some people use ultrasound with site laterality, labeling, but the most important thing is empowering team members to speak up. If somebody sees that you're on the wrong side, to stop the incorrect block before it happens. Speaking again about, this is another study that was published by Dr. Ligori and some members of our group about the checklist process, but talking specifically about HSS, we did develop a restrictive needle technique where nurses provide the needle to the practitioner right before the block is placed. And again, this change was made in 2007. And how what happens now is the nurse actually takes the block needle out and will connect the block needle to your block solution and will hand it to you after your time out. And the nurse is also supposed to stand by your side as you insert the block needle into the patient. And then after that, the nurse can leave. So what are some system level contributors and how can we improve them? So why do our systems fail? Obviously, we have production pressure, inconsistent workflows or not following the workflows, staffing or handoff variability, and then poor reporting culture can contribute. And then reducing the susceptibility to error, things we can do is standardizing our block workflows, having dedicated block areas with the same block nurse or block team who sort of does it day in and day out, having some mandatory documentation fields, and simulation, and also training the team on how this process works. And of course, regular audits and feedback to make sure that we are doing the timeout before placing a block. Now, if a wrong-sided block occurs, what should you be doing? So the immediate response is you're going to stop the procedure. You'll assess your patient for safety and harm. You're obviously going to notify surgical and anesthesia and even hospital leadership. You'll inform the patient honestly, and you're going to document clearly. And then for reporting and learning, so after the event, we'll complete incident reporting. New York City actually uses, or New York State, New York State uses a New York patient occurrence reporting system called NY Ports. So every adverse event is supposed to be reported to them. So I went on their website a few days ago and they had data up to date for 2023. So you can see highlighted, I highlighted wrong side, wrong patient, wrong procedure. And you can see in 2023, there were 125 incidents that were reported to NY Ports in 2023. So this made up 4.3% of all adverse events in New York State. In comparison, the most common was death and serious injury And that was 50% of the that was reported to NY ports, and that was about 1,400 patients. So again, these occurrences are relatively few and far between. Next thing after the event, you'll do a root cause analysis, you share your lesson learned, and then you want to implement some system changes. So I think about 4 to 5 months ago, we did, unfortunately, again, had a wrong-sided block at HSS. And one system change that we did implement was sending out an email now to every month to everybody in the anesthesia team, reminding them as of such and such date, it's been a couple of 100 or 200 or 300 days since the wrong site block. Think safely, work safely, follow these steps, speak up. Again, this is a way to kind of remind our team to keep this in the back of our minds, especially since we are a high volume block institution and we do many blocks multiple times a day. So what are some of the key takeaways that I want to share? Wrong-sided blocks are preventable. Risk increases with complexity and ambiguity. Standardization and teamwork and communication increases patient safety. And of course, how we respond matters as much as prevention. So Raj and Rakesh, again, thank you guys for the opportunity. I really, really appreciate it.
That was wonderful, Jenna. Thank you so much. The wrong side block thing is kind of like a thing I'm paranoid about. And you mentioned the draping. I missed it. One of the things that we struggle with the most is just putting the ultrasound on the right side of the patient.
Yes.
And that can be such a weird, strong cue that we've had near misses because of just somebody put the ultrasound on the wrong side of the bed. It's weird. Those little things can cause us to become victims to just behavioral problems.
Because we're all on autopilot a lot of times.
Yeah.
And I always like to say I personally had a wrong-sided block very early as in my attendinghood. I was 6 months in. I think that kind of scared me a lot. I've become a little bit since then I've become a little bit paranoid about it. But again, placing the ultrasound machine on the opposite side, there's so many little systems, things that you want to do. You want to check yourself at all times, but also having team members that kind of watch you and kind of guide you along the way is very important.
Rakesh, do you guys mark the block site? And if you do, what do you use to mark it? I mean, what do you put on there?
We write block on the block, and we write block on both anterior, like if it's bilateral, or if it is anterior and posterior, we write block both sides. Yeah. So when we turn the patient, we are able to see the backside of it as well.
Yeah. I think block is a good word to put for marking. Initials just get confusing because the surgeons are putting initials, and nobody can tell anybody's initials from each other. So, any other thoughts, Rakesh?
No, we often we often are pressurized to work in a fast-paced environment, and many a times either it's the work pressure or the complacency that that person will do a good job kind of an attitude, which often leads to wrong events or adverse events. So what do you think is the most vulnerable part of the block procedure when you try to do when these things happen? What do you think is the systems level failure?
I think not having that communication, because the nurse should be your backup, right? If I'm on the wrong side, I should have another person that indicates to me that I'm on the wrong side. So I think not having that, that's the factor that I think is the most important one that could be prevented, because you're not doing that time out by yourself. You're doing it with the nurse or a resident or wherever you are. There's somebody else who you're supposed to be doing it with. So if you don't catch it, that person is supposed to sort of catch that for you. So I think that's one of the areas that I think is most vulnerable. Like I said, not everybody does site marking. The surgeons do mark at HSS, but we personally don't mark the site at HSS. It's not part of our protocol. We kind of follow the surgeon's mark at our lead. So to me, that's not what it is. I think having that nurse, and that's why we gave the power to the nurse by handing her the needle and having her be that last stop to hand you needle that you're on the right side before you place that in.
Yeah. Well, thank you so much for joining us on this World Day. Really appreciate your insights. And we are going to move on to our next speaker. You're welcome to join us on the YouTube live stream.
Thank you so much for having me, guys.
Thank you. So as we move on to our next speaker here, I'm going to bring Dr. Jenny Chen on. Hey, Jenny, how are you? And I'm going to get your slides up here too. Perfect. So Jenny, you want to do a quick introduction of yourself? Actually, before you do that, I want to remind the audience, you are welcome to put comments Particularly the Facebook and the YouTube stream, the comments come in really nicely for us. We got a nice comment earlier about Happy World Day of Regional Anesthesia. And Dr. Haskins giving Dr. Ume a nice shout out there. So thank you everybody for participating in the conversation. Put your questions in the comment box. Also just tell us where you're listening from. Where in the world are you that you're listening to our live stream? We'd love to see it. So just type that into the comment box. Jenny, now let's get to you. You want to give a quick introduction of yourself, and then we'll get to your presentation.
Awesome. Thank you so much, Raj and Rakesh, for inviting me. I'm so honored to be here. And Uchenna, thank you for that awesome presentation. I love learning from everybody, and I'm cleared my whole day for this. This is awesome. Good morning, everybody. My name is Jenny. I'm a regional anesthesiologist at OHSU in Portland. I'm also a chronic pain physician, and I spend about half my time at the pain clinic at the South Waterfront. I'm honored to be here to talk about when blocks go wrong, managing postoperative neurological symptoms. This topic is near and dear to my heart because these are my favorite patients to see in pain clinic. And also because I firmly believe that this is such an important way that we can prevent harm in regional anesthesia is to correctly diagnose and attribute neurological symptoms after surgery and to prevent further patient harm.
Well, Jenny, we'll let you take over the slides and continue the presentation. Thank you for being here.
Thank you. All right, let's see. First, we'll talk about the incidence and pathophysiology of nerve injury and postoperative neurological symptoms, which, if I remember, I will abbreviate to PONS. We'll talk about reducing risk for nerve blocks, and then spend the half of the presentation talking about the diagnosis and management of PONS. So the risk for severe peripheral nerve injury after surgery is luckily extremely low. The etiology of peripheral nerve injury is in the perioperative period is complex, multifactorial, still remains pretty incompletely understood. Our best studies to date tell us that peripheral nerve injury is associated with general anesthesia, hypertension, and smoking. It's also associated with certain types of surgery, with cardiac, orthopedic, and neurological surgery carrying the greatest risk. Surgical contributing factors include just creating a very pro-inflammatory inflammatory state, patient positioning, anything that causes traction on the nerves, compression, ischemia, contusion of the nerves, and tourniquet use. So when patients ask, what is my risk of peripheral nerve injury after surgery? I tell them that it's lower than my chance of getting into a car accident while driving home from work. But it's not zero because we still don't completely understand it. Patients can also have postoperative neurological symptoms after regional anesthesia, which can be defined as new onset neurological symptoms, either sensory motor weakness or dysesthesias, in the distribution of the peripheral nerve block, either directly attributable to the block when reported, or reported in the context of regional anesthesia in general. So when patients ask, what is my risk for PONS after regional anesthesia? My answer is it depends. It can be fairly frequent for residual numbness and tingling as your block wears off or sets up, or it can be less frequent, around 15%, that you may have a prolonged block over the next 24 or 48 hours. The risk of long-lasting injury is, again, very low. The overall incidence is low and also decreases over time. This is from a really great review in 2024 published in RAPM. This study gives the incidence of PONS as being approximately 1% at around 2 weeks timeline, which decreases to about 0.03% at 1 year. This is really similar to the rate of overall peripheral nerve injury after surgery from that really nice University of Michigan study in 2009, which included all patients, even people who didn't receive peripheral nerve blocks. So we know that peripheral nerve blocks are very safe, and for the most part, our bodies are pretty good at recovering from that transient injury, but we know that nerve injuries still occur. The epidemiological triangle, as you see here, is an injury model that we use to describe the relationship between an agent, host, the environment. Um, Mechanisms can further be divided into 4 broad categories: mechanical, pressure, chemical, and vascular injuries to the nerves. The safest approach overall seems to be identifying prevention of as many potential risk factors to neurological injury as possible. So we mitigate these risks by minimizing injury to the perineurium covering the nerves, judiciously exposing axonal structures to pressure or chemicals, minimizing trauma to vasculature, and being as fastidious as possible in terms of nerve and needle identification. So the diagnosis of PONS is based on symptoms, history, and physical exam. Early recognition of nerve injury and prompt risk stratification to prioritize those patients that require urgent attention is essential to give our patients the best chance of neurological recovery. Recognition of nerve injury may be difficult where excessive sedation or postoperative pain limits the examination. Also, continuous peripheral nerve block catheters can mask PONS for days, or in ambulatory patients who are lost to follow-up. They're kind of hard to catch. So I have a higher index of suspicion with catheters, surgical nerve blocks, if there's any evidence of nerve swelling on ultrasound, high injection pressures, multiple attempts or multiple needle passes, and paresthesias during placement. Having said that, case reports in our best studies tell us that most of the nerve injuries that are reported and recognized happen without any recognized complications at the time of the nerve block. So you can have a perfect anesthetic, a perfect nerve block, and still have neurological injury afterwards. So symptoms of the nerve injury can present acutely when the block recedes or may become apparent to several days or several weeks afterwards. And symptoms vary depending on the origin and severity of the injury, and it can range from mild intermittent tingling and numbness to more severe, persistent, painful paresthesias, sensory loss, motor weakness, or both. We know that combined sensory motor and pure motor deficits are the most common. Pure sensory deficits are rare, but probably underreported. So when patients ask if I have residual numbness or motor weakness, who do I talk to? They can talk to their surgeons because that's usually the only service where they have scheduled follow-up. They can tell their primary care provider, who is a great coordinator of their care. Ideally, they would have a direct way to get a message to the anesthesiology service that performed their nerve block. At our institution, we have a robust acute pain service that's staffed by regional anesthesiologists, chronic pain attendings, fellows, and residents. This is a snapshot of a patient discharge summary where we give them the number for the on-call APS physician if they run into any problems. And they can call that number 24/7. And this really illustrates how important a service we provide to the patients when we have acute pain trained physicians. So this is the algorithm for the diagnosis and initial therapy of periop nerve injuries from ASRA, updated in 2015. I really like this algorithm because it helps with risk stratification. So it separates into emergent situations and situations where you have a little more time. So in the case of suspected space-occupying lesions associated with neuraxial nerve blocks, we treat this as an emergency because the patients can have rapidly evolving neurological symptoms that may or may not be fully reversible. For complete or for progressive, really bothersome peripheral nerve deficits, both the surgery and anesthesia teams should be notified, and workup should be expedited to allow identification of potentially reversible factors, such as extrinsic or intrinsic compression of the nerves. So is there a tight cast or a dressing that needs to be released? Do we need to pay attention to the possibility of compartment syndrome or hematomas? Our acute pain service sees these patients in-house, or I offer urgent appointments in pain clinic for our patients who are at home. Imaging may be useful to define if there's a lesion or an acute process very early on, rule out hematomas. Electromyography or nerve conduction studies early at less than 7 or 10 days can be really helpful in localizing and separating conduction block from axonal injury, so neuropraxia from axonotmesis. These studies won't provide much more diagnostic information beyond that at this early stage, but there is a role for electrodiagnostic studies at this early time. For patients who are having mild to moderate PONS, the decision to follow up or not depends on the severity and duration of symptoms, and this is a great opportunity to do some shared decision making with the patient. So when they ask, do I need to follow up about these symptoms? At our academic institution, we encourage all known symptoms to be followed up initially via a phone call from the regional anesthesia team. I also encourage them to follow up with either their primary care provider, their surgeon, if they would rather go that route. If the symptoms persist, a physical exam is really important. If the physical exam shows just mild symptoms, then reassurance, empathetic connection with your patients is really key to alleviating patient anxiety. I also offer follow-up within a couple weeks to review the need for further diagnostic tests. If patients are very anxious, I offer more frequent follow-up or check-in phone calls earlier. If there's any motor involvement, difficulty in localizing the injury with the expected distribution of the nerve block, if I think there's anything else going on, if there's complete absence of nerve function beyond the duration of the peripheral nerve block, or any severe functional limitations or progressive deficits, then an early pain or neurology consult is definitely needed for those patients. My goal in these situations is to be as accessible to these patients as possible from a follow-up perspective. I want them to turn me away if they don't need me. So when patients come to follow up and ask, what can you do for me? I tell them that we have two goals. One is to investigate the underlying cause, and two is to treat symptoms of pain and dysfunction. EMG, or electromyography, and nerve conduction studies can be really great tools in the subacute period. EMG studies look at electrical activity generated within a muscle, and they can determine the muscle units affected by the injury. 3 to 4 weeks after injury, you can see fibrillation potentials on EMG. That can be a sign that there's denervation going on. You can use nerve conduction studies to localize the site of the conduction block, and that may be really helpful in confirming or refuting that the nerve injury is consistent with a peripheral nerve block injury. Peripheral nerves are very nicely topographically conserved, meaning that they have a really consistent internal fascicular organization, and that helps with lesion localization and to guide targeted repairs if those are needed. It may not always be possible to distinguish between anesthesia and surgery-related causes when the surgical incision site, the block site, and the tourniquet are all in close proximity. But these studies can help. Electrophysiology studies can also offer prognostic information depending on the degree of injury found on examination. Now, if there is a known nerve injury, a nerve injection, or an intraneural injection, we may wait to get the EMG at a couple of months just to document recovery and decide next steps. In the meantime, we can always use non-opioid analgesics to treat pain. And if there is dysfunction, connecting them to physical therapy, occupational therapy, or physical medicine. So what can be done if I don't get better is a question I hear from patients often. So unfortunately, no pharmacological therapy has been demonstrated to enhance neural regeneration, but we still have some pretty good treatments for the sequelae. Treatments involve physical therapy to maintain muscle mass and prevent flexion, contractures. We can also use pain medications. We can escalate up the analgesic ladder and escalate these medications to therapeutic effect. When there's incomplete or there's no improvement by about 3 or 5 months, that's when we think about repair, and we can refer to a peripheral nerve surgeon, plastic surgery or neurosurgery, to talk about surgical techniques. And there's really cool research coming up in restoration of neuromuscular function by either neuromodulation or brain-machine interfaces. That's going to be really cool coming down the road. So in summary, most postoperative nerve injuries are unrelated to regional anesthesia, but postoperative neurological symptoms should be evaluated early for reversible factors. Reassurance is extremely important for mild symptoms. Risk of permanent PONS is pretty low, and management for persistent PONS is multidisciplinary and can include imaging, electrodiagnostic studies, medications therapy, and definitive surgery if needed. Thank you guys so much for your kind attention. These are the 4 little reasons why my voice sounds a little hoarse today.
Wonderful.
Yeah, thanks for the amazing presentation, Jenny. I had one question myself. In your practice, what major complications are often dismissed early on as insignificant, and which practitioners should pay more attention when patient reports with PONS? Do you have any guidance to practitioners?
Yeah, I think overall, as anesthesiologists, we're really good at catching red flags early. I think where we run into problems is when we don't have access or follow-up to our patients. And that can sometimes come from our surgery colleagues as a way to not bother us, right? If they have a patient with a wrist drop or a foot drop after surgery, the surgeons can reassure these patients and say that this will get better. It usually gets better, and then they don't want to bother us by telling us about it. And I think we need to have more communication with our surgeons, because if that happens, it's better for us to know about it earlier than not. And that way we can follow up and just make sure that things don't get lost to follow up, that we can order diagnostic tests early and we can just stay on top of things.
And how do practitioners, do you have any words of advice how practitioners reach out back to the surgeons and still convince them to go ahead and access blocks when bad events happen? Do you have any thoughts on that?
Yeah, I think relationships are so important. It's definitely a delicate conversation to have, especially when things go wrong. It really helps when things go wrong to come together as a team and really talk about the different factors. I think that we do so much good in regional anesthesia that we really need to have, I guess, productive conversations around when things go wrong, and keep in mind that it's important for us to really delve down into the root causes of these postoperative neurological symptoms and not just let everything get blamed by anesthesia, because our best evidence tells us that 9 times out of 10, a postoperative neurological complication is attributable to the surgery and not the anesthesia itself.
Jenny, thank you so much. This topic is obviously weighs heavily on most of our minds as we're doing regional anesthetics. None of us want to cause harm to our patients in the process, but I think we have to have our eyes open that these things can happen, and good communication, good preparation is critical. Thank you so much for joining us for this presentation. And like I said to our audience, keep throwing in questions. I think there was a comment that the surgeons don't want to bother us about neurologic complications. That's such an important insight, is that open line of communication is so important to making this work properly, both directions. It has to go both ways. So thank you so much, Jenny. Appreciate having you here. All right, I want to remind everybody that we do open the comments, so feel free to put your questions and comments in there. We'll try to bring them up with the speakers when it's appropriate. And also, I think we have little shout outs here. We got somebody from the Seychelles listening to us. We've got a friend in Israel listening to us, celebrating Happy Regional Anesthesia, World Regional Anesthesia Day, and from our friends up north in London, Ontario, Canada. So wonderful. Yeah, please share with us where you're listening. And we'd love to kind of see all the audience members from all over the world. I'm going to jump into our next group here. We've got Dr. Cliff Bowens, who's near and dear to my heart. His office is 2 doors down from mine, and Dr. Brian Allen, who's not far from that. So 2 of my colleagues at Vanderbilt University. Hey, Cliff. Hey, Brian.
Hey, Raj. How are you doing?
Doing great. Good to have you here. We've been surviving Ice Storm 2026 here in Nashville. So the fact that all 3 of us have... You can't hear me right now? Cliff, let me check your audio settings. Let me see if... Hey, Cliff, can you hear me now?
I initially could hear you, but I can't hear you. Can you hear me?
Yes, we can hear you. Let me just text him here. So
all right,
we'll keep doing
put the slides up, see if it comes back then.
Yeah, we'll try that in a second here. But if you want to hit the little gear icon, well, he can't hear me. So, all right, yeah, we can hear him. Yeah, this is the challenge with live streaming, is we've always got some audio and video stuff to deal with. But what I was going to say was that we've had an ice storm over here. We're just glad we have power. That was the problem earlier this week.
Yeah, yeah, Raj, can you put the slides up? I can't hear you guys at all.
Yeah, let me put the slides out. Let me see how he's doing here.
All right. All right. So I assume you guys can hear me. Is that correct, Brian? Okay. So what I'm going to talk about today is we're going to talk about a little bit of technology in medicine and anesthesia. When I was looking at this talk, one of the things that I noticed is that, we were going to talk a little bit about artificial intelligence. And when I was thinking about this talk, I thought it was very important, the fact that we don't have a good understanding of how artificial intelligence works. And I thought it would be a good time to sort of kind of talk about that, how artificial intelligence, how these programs actually do work, and then apply it a little bit to medicine. And Brian's going to talk a little bit more specifically about some applications in regional anesthesia. So I don't have any disclaimers, and I don't think Brian has any disclaimers. And we will talk about AI, and this is sort of kind of a good starting point, because everybody wonders about what is the effect as AI is going to have on our future in medicine. So I'm going to talk a little bit about the definition of AI, a little bit about the history of AI, because I think that it allows us to understand why we are where we are, the types of AI, how does it work? And that is the main part of this. I really want to talk about how does it work? How does these systems work? And what are sort of some limitations that you can be enlightened by understanding how they work? And then we'll talk about applications of medicine and anesthesia. As I mentioned, Dr. Allen will talk about that, and then we'll have a little discussion afterward. So the definition of AI is computer science aimed at creating systems that are capable of performing tasks that typically require human intelligence. These tasks include reasoning, learning, problem solving, perception, and language understanding. The scope of the AI is how do we actually accomplish these tasks? And a lot of times they use systems to do that. Rule-based systems, symbolic reasoning, machine learning, and neural networks. So a little bit about the history. In 1956, Dartmouth had a summer research project, and John McCarthy had been doing some work on AI, and he coined the term artificial intelligence. And he also, I think, was one of the first people to do one of the languages associated with artificial intelligence for programs, which was the Lisp language, LISP. In the 1960s and 70s, there were expert systems that were developed. These systems were had a small domain. They used experts like physicians to come up with something specific that they could be used to help solve a problem for. MySim was one of these expert systems, and it was used to make diagnosis for bacterial infections and recommend treatments. In the 80s and 90s, machine learning and something called neural networks were developed. This actually improved the performance of these systems, because one of the things that you need layers of computations to be done, and that's done through these neural networks. A component of neural networks and a an increase in the use of these things came with something called deep learning, and this was developed in the 2000s. And this was key in terms of developing the technology that we need for image and speech recognition. In the 2020s, they came up with better natural language processing, and they have something called large language models that you can use for interpretation and generation of human language. And one of the applications of that is ChatGPT. This right here, there were some other things that happened in medicine in terms of developing some of the ideas for it. And one of them was Leonardo da Vinci. He had some sketchbook that he did in like 1495, but it was discovered in 1950s. And it showed some robotic images. And one of the things that happened from that is he had an influence on people developing robotics. And this system right here is a robotic system that's used for prostatectomies, gynecological surgery, and other surgeries. And it was named after him, the Da Vinci. It has the arms to the right. You see the arms, and the arms are used inside the patient, and they're controlled by the surgeon, which uses a console, which is on your left. And then in the middle, you have a monitor that you can use as well. Let's see, for other people outside of the surgeon to see what's going on. So AI is broken up into 3 different types. One is artificial natural intelligence. This is a supervised learning system. There's supervised, unsupervised, and reinforced learning systems. And we're just going to talk about supervised. But this is what's used for Amazon, Alexa, Siri, Google Assistant, and self-driving cars. It uses, well, we'll get to it in a second, but it uses basically inputs and outputs in order to determine how the language is used. And then there's general AI. This is still in the area of artificial neural intelligence. However, it uses more complex neural networks, larger data to produce these high quality media, text, images, as well as audio. Last is artificial general intelligence. This is when computers can do anything a human can do. And a lot of times we think that we're close to that. We are really not close to that. In order for that to happen, the computer would have to be able to actually have physical control to be able to move around like a robot, and then also have the mental capacities associated with the human. A lot of times we think about this, and it's a concern of people because of the explosion of AI that we've seen today. So we're going to talk about supervised learning, and we're going to show some examples of this and how this actually works. So you have an input A and an output B. And the way this works is you train the system on the input A. You actually have what the system would normally see. So you'd have a large database of things that would be input, and then you'd also have what the appropriate output would be for that. So in the training phase for these systems, you'd have both input and output, and you do a direct mapping. So you would be telling the computer here's your input and here's the correct output. And so for email, the input for an example, email, the input is the email, and you're looking for, is this a spam or not a spam? And you would have a 0 or 1. If it's a spam, say that's a 1. And this could be used in practice for spam filtering. Audio. So if you have someone that you're speaking to, say you're speaking at Siri, it would take the audio and then it would make a text transcript of that. It's like you want to say, Siri, send an email. It would be able to do that, and that's speech recognition. You also have English to Chinese translation. That's a machine translation. You have ads that where you are browsing on a computer and it keeps track of what you've been looking at, and then it makes recommendations for future things that you might be interested in. That's where you see those ads popping up. Image radar and information, as well as sensing around vehicles, can determine where other vehicles are at, and this can be used in self-driving cars. An input of an image of a phone that has a defect on it. This is not the picture, the phone taking a picture, but say there's a defect on a phone, or say a coffee mug might be better. And you take a picture of that and you have a number of pictures of defective cups, and then you, for your output, and that can be used for visual inspection, like if you were doing that for a manufacturing company to see if you had a damaged, say, mug. And then sequence of words is being able to determine what words you have, and then what word follow that. That's how chat bots work, or chat GPT works. It actually can predict what word should follow. So let's see why is this happening right now? One of the things that we discovered is there's a huge explosion in the amount of data that's available. And a lot of times in the past, we'd have data that was available in paper form. Now we have a lot of data that's available in digital form. Digital form can be fed directly into computers to utilize that data in order to generate the learning that computers need to have. And we're going to talk a little bit about that a little bit later on. But if you have data only, the performance of the computer, even if you give a lot of data to it, sort of plateaus off. And that's that red line you see, traditional AI. Then you add neural networks, and we're going to show these a little bit later on. You add neural networks, you have a small neural network, and you have an increase in performance. You add a larger neural network, and you have an even bigger increase in performance. And finally, you have a large neural network that produces the largest benefit. And that's where we're right now with these large neural networks. And they can generate can have input, the type of data that can generate the outputs that you need in order to have, for example, speech recognition and language processing. The two things that are important for these large networks to have is one is you have to have large databases to feed into the system. And the second thing is you need high performance of these units, in particular GPUs. CPUs are central processing units. GPUs are graphic processing units. And these graphic processing units work better in terms of being able to code for these large neural networks. So here's a neural network, and I'm going to go around this real quickly and talk about this. Deep learning is just multiple layers of these neural networks. Sometimes they're called neural networks, and then sometimes it's called deep learning. The buzzword today more is deep learning, where they have these huge networks, and this is very, very small, by the way. What this shows is you have input of, you're trying to figure out, well, how much should I sell my house for? So you have an input of size, number of bedrooms, number of bathrooms, and newly renovated. And you have all these inputs that go into the system, and once it's into the system, these neural networks compute and communicate with each other in order to process the information and produce a price for you. The way this works is, and then, as I mentioned, it's A to B mapping. You would have initially a bunch of homes that have all the input information, and you'd have a price on the other end. So you would train the system by having a bunch of examples put through the system, and you'd have the right outcome. If the outcome is incorrectly, that's fed back to the system. The system makes adjustments, and then it feeds out the right answer. And if you reiterate this multiple times with large databases, then you start getting consistent prices coming out. So there's two real important components with it. One, you have to have large data to push into the system so it can learn what it needs to put out correctly. And then it also has to have a feedback in it, feedback loops through it, so that it can adjust the parameters within the program so that it, in essence, learns what it needs to do in order to produce the right output. Once you have that, then you would run a test data set to see if those answers are correct, and that allows you to determine if the program is indeed working correctly. As you can see, that this is not something that is intuitive. It takes a lot of input in order to make these systems work, and human input. So this is another example. This is a facial recognition program. So you take a portion of this facial recognition, you see the eye portion, and then the computer, what it sees is it maps that to pixels. The pixels are numbers, and that'll be associated with a certain grayscale if you're in black and white, a certain RGB scale if you're in color. And then every area of the face is made up of those pixels, and then it can analyze the areas of the face to see if that face is something that is seen previously. So this shows an example of that picture going into the system. And the first layer of processing, and this is after this neural network has been trained, by the way. The first processing, you just see sort of the outline. And then the next set of nodes or neurons that you see is some construction of parts of the face, nose, eyes, etc. And then the last one, you actually see a face, and then it can actually see, is this the face of the person that previously was identified into the system? And so you'd have your identification, yes or no. What can't neural networks do? The first thing they can't do is typically they work with things that you can repeat continuously and things that can be determined in about a second of thought. So if you look at a car, you can see, if you're driving and you look where a car is at, you can determine where that car is in a second. If you're talking to someone, you can determine quickly what they say. That's what neural networks can do. It can do things that are relatively simple. What they cannot do is they cannot diagnose. If you have 10,000 images of pneumonia cases that are on X-ray, and you fed that into the system, and it can compare that to a new patient that has a pneumonia, it can determine that the patient has a pneumonia. It cannot do that if you give it like 10 images of that patient and give it some text to read about that and say, make the diagnosis. So the bottom line is it takes a lot of conditioning of these systems in order for them to perform at a high level. And that's that data that's put in the development to develop the neural networks or the deep learning. So how is AI used in medicine? Well, the first thing it's used obviously is to make diagnoses. In radiology, ultrasound, it can be used to make diagnoses for tumors and other things. Drug discovery in pharmacy is also being done, genetics, molecular medicine. Medical records are being maintained with these systems, as well as regional anesthesia records, healthcare systems, surgical robotics. I mentioned Da Vinci, and then medical education.
Hey, Cliff, can you hear
yes.
me? Okay.
I can hear you now.
Okay, good. Hey, I may have to cut you short here just because we want to try to keep on time. I know this is such an important topic.
Well, this is like my last slide, and then Brian's
perfect. Okay.
for a minute. Yeah. So, and I'll just switch it on over to Brian to go ahead and take over and finish up these last few slides. Brian, I'm going to let you go here.
For regional anesthesia, there are a number of tools that are developed, and the excitement around AI essentially is such that it's likely to be seen in many, many different machines built going forward. There's a lot of overlay and teaching tools around it. And really the goal here is you would need to really test it and find the use case for your environment. Next slide, please. Onward. Oh, yep. And then there's a number of AI tools that are in the market now. There are. This is just a few of the tools available. There will be a great sorting out, and there are billions of monthly uses of ChatGPT and others. Next slide. And then the last thing is that the ones that are popular now may not be popular, may not be the biggest models or the most used in the future. And so there's a lot of sorting out in the market for what's available. So don't want to keep your live stream too long here, Raj.
Well, thank you guys both. Like I said, this topic we could talk about for so long, and I think the role of AI and all this technology, I think the battle we're going to find is where is it useful and where is it causing us almost a crutch or a harm in our clinical care. And I don't think we know the answer to that yet, and I think that we're still sorting that out. Some of these things become distractions instead of useful. But I think our friend James Bonus always says that it behooves us as clinicians to be leading the charge and deciding how AI is used and not necessarily just reactive to what engineers and technologists throw at us. So understanding it, like Cliff, you've explained it so well for all of us who are new to this, is understanding the technology is critical to being able to kind of guide people on how to use it properly.
I think playing in a low stakes setting also before considering and really adopting something shiny and new that you don't really understand, using it in a low stakes setting first before implementing in a bigger way is really important.
Well, thank you both for joining us on this World Day of Regional Anesthesia and contributing to this conversation. Thanks, Cliff. Thanks, Brian. Stay warm. Hope power stays on for both of you.
All righty. Thank you.
All right. Take care. Awesome. So, Rakesh, while you're getting ready to queue up our next section, yes. I'm going to throw up a couple things up on the screen for people just so that they know it's coming up. We do have our ASRA spring meeting coming up right around the corner, April 16th through the 18th. This is in Phoenix, Arizona. Make sure you go to ASRA.com and register for this meeting. It's going to be fantastic. Great. Lots more of this type of content at that meeting. And you can go meet these speakers and talk to them in person at length and really enjoy this conversation even further. And then in the fall, we have our fall meeting. That's going to be in Tampa, Florida, November 5th through the 7th. So again, ASRA.com has all the information about both of our annual conferences. So I just want to remind people that those are coming up and to look out for those details about registration. All right, go ahead and introduce our next speaker. I've got him on deck here. I'll bring him on in just a second.
So the next session is to talk more about how innovation collides with clinical reality. Innovation has always led the practice of regional anesthesia forwards, but adoption sometimes outpaces evidence. So there are newer blocks, newer techniques, newer subspecialties where we apply regional anesthesia every day more and more. So this session critically examines the newer therapies available and the newer subspecialties where we are applying regional anesthesia. And the first talk is by my very dear friend, Hisham, who I know him for a long time since his Cleveland clinic days. He has led the innovation in peripheral neuromodulation for a long time. So the first talk will be on past, present, and future of peripheral nerve stimulation. It's followed by applying regional anesthesia on uncommon anesthetic indications like urologic surgery and cardiac surgery. Hopefully it becomes more common. And also another important topic of managing chronic pain management in pregnancy later on by Jarna Shah. With no further ado, I'll let Raj.
Welcome, Hisham.
Hey,
Great to
how are
have
you doing,
here,
everybody? Thank you for having me.
So good to have you here. And I'm going to get your slides up here. I know we're running a little bit behind, but there's so many good topics here. It's hard to cut people off. Hisham, you want to try? Oh, perfect. Everything looks great. So we're going to let you take it over, and hopefully we'll have a couple of minutes to chat at the end. Go for it.
Sure. Thank you very much for having me to be with the great leaders, innovators, researchers, and friends. Good morning, good afternoon. So it's very difficult to talk about just the peripheral nerve stimulation just in a short time, like a 10-15 minutes. My name is Hisham, I'm professor of anesthesia at Case Western. I work at Metro Health Hospital. And I will try to, in short, give you an idea about the history and the current situation and the future of peripheral nerve stimulation. This is my disclosure, and I will discuss some of the technologies that I have some conflict with, but no off-label investigational use of any of those products. So the history of peripheral nerve stimulation is go back a long time ago. And the first documented peripheral nerve stimulation was the old Egyptians. There is a lot of documentation more than 4,000 or 5,000 years ago, documented that the old Egyptians used the peripheral nerve stimulation form in a form of a catfish, a Nile catfish, that they use it and put it in the part of the body to help the pain. So this is kind of the first description. Then after this, by around 3,000 years, the Greek and the Roman also documented the use of peripheral nerve stimulation. So just as kind of the oldest way of managing pain in history. And then in the first description in the modern history of the peripheral nerve stimulation come to the 1962 to 1967 by using the stimulators directly over the nerves in the trigeminal neuralgia. And it's kind of important to know that kind of the earliest evidence in the facial pain, and even with later when we discuss the percutaneous approaches, also with the facial pain, still underutilized for many reasons. But this was kind of the first description, and even the description was the physician that they did this apply for themselves actually. And then historically, the peripheral nerve stimulation progressed, but it was mainly done by surgeon, by open exposure and surgical dissection. They visualize the nerve and they place the leads around the nerve surgically. This definitely affect the access of this technology and also led to a complication like a development of adhesions, fibrosis, and more nerve injury, and they're trying to do some modification by putting facial grafts around the nerve. Still the adoption and the complication rate was high. So this kind of give you an idea how progression is the peripheral nerve stimulation from 62, as I mentioned, 67, and then the first description of a percutaneous approach of the peripheral nerve stimulation, which will be fit more a pain physician and regional anesthesiologist, just insert those leads percutaneously in 1999. But it still takes time, 10 or 20 years, till we get real FDA approval, because during those 20 years, most of the procedures was using leads that was not designed for a peripheral nerve stimulation, that was designed for spinal cord stimulation with the big battery and different design of the leads. They put it peripherally, which lead to, as you expect, to complications. But then many companies and many technologies advanced, and we have a specific leads only for peripheral nerve stimulation, and lead to many adoption of many societies of the technologies. Important to distinguish many definitions when you read about these technologies, what we talking about, what we interested in, what it's have the evidence, it's a direct peripheral nerve stimulation. What I mean by that, you identify one nerve as the pain generator, and you have an imaging technology that allow you to localize this nerve, and you put the wire or the leads close to that nerve to stimulate this nerve. So I have a direct one nerve or two nerves, and you're directly putting the leads around it. Peripheral nerve field stimulation, you putting the wires or the leads at the area of the pain. Transcutaneous electric nerve stimulation, the TENS unit, it's just the skin, stimulate the skin receptors. There's other also new technology, you may hear about it, like a static magnetic field and magnetic peripheral nerve stimulation. So it still provide an electrical field around the nerve externally, but by applying a magnetic field. So this is also a different technology using a different modalities. Very important to see the lead design. So And mainly in the market now, there is a two lead designs. The classic multiple contacts leads, which is the same leads structure as in the spinal cord stimulator. It allow a complex stimulation, a bipolar and a cathode configuration. As you see in the image in the left side, this is the conventional BNS, which you have to put it closer to the nerve, and it have some advantages definitely, but because it allow you have a complex programming, and also it's a permanent implant, but have some limitation because as you increase the power and you have a limited number of the A alpha and beta fibers to be activated, and it lead to activation of a non-painful nerve fibers, we can say that. The other type of lead design is the monopolar. It's just simply one contact. It creates a large area of stimulation, which allows to put this lead a little bit far from the nerve, and this allowed kind of selectively to activate a larger number or a larger proportion of A alpha and beta fibers. There's a lot of details we can talk about, but because of the limited time, I want to give all the audience just a sense about the design and different ways of stimulation. The monopolar that I mentioned, it creates a big area of energy. So you can put it parallel to the nerve, you can put it perpendicular to the nerve. This relationship is not that important. And also putting the lead remotely to the nerve give you some safety option here. The other classical bipolar leads, you have to put it close to the nerve. And to increase the number of contacts that stimulate the nerve, it is better or advisable to have a parallel relationship between your lead and the nerve. You can still put it parallel, but maybe this will give you a less number of contacts around the nerve. The mechanism of action is a complex, have a central mechanism and peripheral mechanism. The central mechanism inhibits the signals from the dorsal horn, wide dynamic range neurons. The peripheral mechanism, it disrupts the nociceptive afferent and alter the local environment and a lot of inflammatory mediators. Again, I'm sorry, I cannot go through all the details about especially the mechanism of action. The waveform is also critical. When you apply those technologies, you want to know what type of frequency that you aim to deliver to the nerve. Is it low frequency? Usually the low frequency range less than 20, which will give you a motor stimulation. Usually the thinking that we want to avoid the motor stimulation, but actually maybe not. And there's a lot of interest now in actually providing a motor stimulation to help the pain, which for example, hemiplegic shoulder, low back pain, it's the big target. And also now for a knee pain, doing a motor stimulation for the quadriceps muscle, for example, can lead to a pain relief and also indirectly definitely rehabilitation role. The mid-range, which is the majority of the stimulation, which is 20 to 100 hertz. And then also recently is a lot of interest in the high frequency and ultra high frequency. The ultra high frequency, which is very, very high frequency, more than 500 hertz, which is still investigational, it actually provides a nerve block. So it simulates the local anesthetic that we inject around the nerve by delivery of a very high frequency. And then the advanced programming, which can combine both two and different ways of delivering the shape of the waveform to the nerve. There is two big category, the temporary or the short-term peripheral nerve stimulation, which is FDA approved for 60 days and started using in acute pain actually over like around a decade ago. But now they are using it more in the chronic pain ward, but definitely have a big role and in use in acute pain situation, but in a little bit limited role. This is a temporary device, they put only for 60 days, and it could have, it's the structure, it's a small coil. And this coil structure allow fibrotic ingrowth or less risk of infection because you're going to leave it for 60 days, externalize it. There's no internal pulse generator. You connect it to an external pulse generator. But the nature of the coil decreases the risk of infection and also not only that, the risk of migration because it moves with the tissues around it. But this is a temporary device only used for 60 days. There's some evidence showed it even after the 60 days therapy, it still allow some pain relief after removal of the lead. So it can use being acute and subacute pain. It have a great role in chronic pain. The permanent implantation system, which are like spinal cord stimulator, usually you go with a trial. I mean, you put these wires for the patient or the leads for a week. The patient tried. If he had a good response, you implant it by a minor surgical procedure. There's many systems, and the systems now, as I mentioned, not the same as the spinal cord stimulator, and great advances in the technology of transfer the energy from externally to internally. So those devices does not have a battery. It's just a simple wire. You insert it close to the nerve, and the patient have to use an external device that deliver the energy through the skin, through the tissue, to the simply the lead and lead to the action. Those are the available systems that available. The reactivate one is the one with the battery. So it have internal battery and it's only used for back pain. Those are different designs of the external wearable that deliver the energy to the lead. And very important with the patient selection that you are doing some sort of selective nerve targeting. Which nerve is important? One nerve or two nerve? Can the patient reach this area? Because the patient will put his hand or can reach out to this area to externally put the device that will deliver the energy. Because again, those devices, the majority of them does not have a battery inside. It's just the wire and the patient have to use an external device. Patient for the permanent implantation have to have an MRI, so you have to have a system that MRI compatible. And the kind of the important question, especially when we have the option of temporary devices and we have the option of permanent implantation devices, which one do you use? So this is kind of a general guidelines. If the patient have relatively 6 months of a pain, relatively acute and subacute stage, you're going to think about doing nerve blocks, catheters, maybe radiofrequency ablation. When the pain is 6 months or the patient have chronic pain already going for a surgery, you will think about the temporary 60-day option. But generally, when the pain is more than a year, multi-year history of pain, usually those patients require a permanent implantation. Just a general guidelines, there is no strong evidence for those recommendations. The techniques of insertion of peripheral nerve stimulation, you can use the ultrasound, definitely, and it's difficult to be good in peripheral nerve stimulation and establish really a good experience and good practice with the peripheral nerve stimulation without ultrasound experience. Some nerve targets, the use of ultrasound is critical. You cannot do only fluoroscopy, like for example, the brachial plexus or the femoral. Some targets are very good with the fluoroscopy. For example, the genicular knee and the cervical median nerve branches. Only X-ray is a decent option to use them. Many strategists, some will advocate to use a nerve block before the stimulation. It's mainly to isolate the nerve target, not to expect or prognose, to have a prognostic ability for the response for the stimulation. Because when you do a nerve block, you block the sodium conduction. When you do a nerve stimulation, you actually improve the action potential. So the mechanism of action between doing a nerve block and stimulation is kind of opposite. So there is no prognostic value of doing a nerve block and expect the result from the stimulation. Sometimes during the procedure, you test motor, you test sensory stimulation. Sometimes you want a motor stimulation, the trajectory of the needle using ultrasound and X-ray together. Important which system you're going to use. Some system, as I mentioned, the permanent implantation, you want to have more of a parallel relationship with the nerve. Very important anchoring. Those leads need to be anchored to the tissues. Different designs of the lead that help anchoring and make the lead stay were around the nerve target. For example, the 60-day therapy have a small spring coil, so this will allow the movement and anchor to the tissues. The other permanent implantation, as you see in the right upper corner, it have tines, and those tines are proximal to the contact. So you have 4 contacts, and the proximity for the contact is those 3 tines that hook to the tissue and help anchor it. Other system, for example, for the back pain, because back pain, especially the back area, is a lot of movement and you need back and forth movement. So those wires have tines in both ends of the contacts, proximally and distally. So this allows back and forth movement so the lead stay in place. The level of evidence is a lot of evidence. Some nerve targets have a high level of evidence, level 1. We cannot have like mention the whole literature in the review article, but you see a surge and increase exponentially in the number of the publication in the peripheral nerve stimulation field. Some areas they have a level 1 evidence, for example, the post-stroke shoulder and the occipital stimulation. And as you see in the bottom of the schedule here, level 1 with the also post-operative pain and post-amputation pain. So using an acute and subacute pain, it have a level 1 evidence according to many review articles. One special about the back, this system that's available for the back muscle stimulation, it's a peripheral nerve stimulation. We put it around the median nerve branch, which is closer to the area of the erectorospinal muscle. It stimulates the multifidus muscle, which is the small muscle medial to the erectorospinal muscle, but also can stimulate the erectorospinal muscle. And it have a battery. So there is no external, they use external, but they have a battery inside and have a very good evidence. This is also a use of a peripheral nerve stimulation. Be comfortable with ultrasound and have experience with regional anesthesia. That will encourage my trainee. It will open the main nerve targets. Many nerve targets get you see the next 2 slides before I close are from the regional anesthesia. For example, the costoclavicular approach for the infraclavicular bricks. It's a good place for a peripheral nerve stimulation implantation. Make the lead secure, cover the whole upper extremity below the shoulder, and also putting the leads close to the cervical erectorospinal muscle. It's very useful in many indications. Also a craniofacial indication, which now approved by the FDA, combining X-ray ultrasound for the SPG and other terminal branches in the head. It's also useful. Occipital nerve, it's a great target with a parallel approach. Also, it's very useful to have an ultrasound skill to allow you to localize the nerve better. For the thoracic pain, for the thoracic neuralgia, also putting the leads near the DRG or near the thoracic paravertebral space. Also, it's a very good target, which again, the experience from the regional anesthesia side, experience from the ultrasound, it's a great to have to better localize those. There was interest definitely and still interest in the facial plane blocks and a lot of anatomy of the facial planes. Those facial planes have nerves. Using ultrasound also to define those facial plane, but not injecting medication, putting bleeds in those facial layers that now we are more knowledgeable about them. It's a great target for many location and many nerve areas. And even for a non-pain indication, for example, the vagus nerve stimulation, there's also a lot of interest, a lot of use in this, and using ultrasound to localize the vagus nerve in this area is also important. It's an area of a great research that also I'm working with my team in. So in conclusion, in short, and there's a lot of information definitely there, but it just to give you a great idea, it offers a significant potential to address very complex peripheral neuropathic pain in acute side, subacute side, and chronic pain. Successful implantation require technical challenges, but also understanding ultrasound, X-ray, combining both together and using the right system for the right patient. Consider many factors, and there is a lot of advanced technological in the wireless stimulator and become more compact, smaller, less invasive, very or not very, kind of easier for a proceduralist, that's a non-surgeon like us, to implant, and a lot of also programming capabilities and sensing capabilities. So the leads now can sense and the sense the action potential and act to it. So it's a lot of advances. So I thank you very much, and hopefully we can have questions. I'm happy to answer or answer any email. Thank you very much, everybody.
Thank you, Sham. Obviously, another big topic. We're just touching barely the tip of the iceberg on peripheral nerve stimulation, and your passion for this technology and the therapeutic value of it is very obvious. For the sake of time, I think we may delay the questions, but I do want to tease people that, that's what these conferences and stuff that we have both in America and Europe. Oh, we lost Hisham there. That these conferences that we have in Europe and America, this is where the opportunity to have these conversations and discussions really shines. And Oh, there he is. Okay, great. And so we just want to thank you for kind of giving people an introduction to PNS and what the possibilities are, and the fact that the story's not over.
Thank you, Reg. Yeah, thank you for having me. Just scratching the surface, and as you, the interest is it's very up from all aspects.
Yeah.
More advanced AI also it have a role. Ultrasound technologies combining ultrasound, X-ray, and the devices themselves became smaller, less invasive. The surgical skills that you need to implant them, it's getting easier and easier. So this allowed a non-surgeon to apply those modalities. But I would say the main obstacle for this is approval by insurance to provide this technology to give it to the patients.
Yeah. Well, thank you so much, Hisham, and looking forward to seeing you in person soon again and talking more.
My pleasure. My pleasure.
All right. Have a great day.
You too. You too.
Well, Rakesh, while we're bringing up our next speakers, you want to throw up some of the comments from some of the other people that told us where they're from?
Yeah, I want to give a shout out to Sri from UVA, and we have audience from UK watching this right now, and also Kosovo, which is amazing.
Yeah.
I also saw people more people in the UK watching this as we speak, and of course the East Coast, West, the chilly mornings and afternoons. Despite that, people are tuning in.
Yeah, I think it's chilly everywhere. So New York, Memphis, Atlanta, they all said they're freezing cold.
Yeah.
Well, we're nice and toasty inside, and we have our next speakers up here, Yabo and Paul. Welcome. Thank you for your patience, and thank you for joining us. You guys are going to be talking about using regional anesthesia beyond some of the usual scope into some categories that maybe people haven't thought about. So I'm going to leave it. I'm going to put the slides up and let you guys take the show.
Perfect. Thank you. All right. Good afternoon, everyone. Thank you for the invite, Raj and Rakesh and Nabil. So my name is Yaba Musay. I am the Division Chief of Regional Anesthesia and Acute Pain at University of Virginia Health System. And I am joined by my colleague and friend, Dr. Paul Gallo, who is a cardiac thoracic anesthesiologist and a critical care provider at UVA. And the title of our talk is Beyond the Usual Scope, Regional Anesthesia for Urology and Cardiac Surgery. We have no conflict of interest for this talk. So I'm going to start off talking about regional anesthesia for urology surgeries. Most of us know that regional anesthesia is a great tool, can be used for primary anesthesia, or can be used to control post-op pain after surgery. It's very common to use regional anesthesia in surgeries such as orthopedic surgery, open abdominal cases, vascular cases, and obstetric. However, so for some reason, we don't really think about regional anesthesia when it comes to urology surgery. This may be due to some of the traditional blocks like the dorsal-penile blocks, which are not often done by the anesthesiologist, but done by the urologist. And also some of the urology cases are typically complex and it takes a long time to do. So we tend to lean towards regional anesthesia, towards general anesthesia. But however, I hope with this talk that we can all consider using regional anesthesia for some of the urology procedures. So here are my objectives. First, we'll talk about the indication and benefits of regional anesthesia for urology. Then we'll talk about some of the types of peripheral nerve blocks that can be used. And then I'm going to focus on peripheral nerve blocks for percutaneous nephrolithotomy, PCNLs. I chose this procedure because this is a common procedure that are done in ambulatory surgery centers. And according to some data, about 90% of them are done in ASCs. And we all know with ASCs, the goal is to get the patient out as soon as possible. So what are the indications of benefits of regional anesthesia in urology? You can use them for TURP procedures. You can use them for bladder surgery. You can use them for circumcisions. You can also use them for uteroplasty, PCNL, and also for nephrectomies. Some of the benefits includes decreased opioid use, decreased risk of respiratory complications, decreased risk of post-op nausea and vomiting, and also it can help with early detections of signs of TURP syndrome, for example, confusion, nausea, or vomiting, and it's also great for faster recovery. So let's start off with some of the nerve blocks that we can use for urology. Like I mentioned, the dorsal-penile blocks. These are blocks of the dorsal-penile nerves, which are branches of the pudendal nerve. Like I mentioned earlier, urologists typically do this block, especially in pediatric urology cases. However, it's good for anesthesiologists to know how to perform these blocks. These blocks are indicated for circumcisions, uteroplasty, and also to repair the penile laceration. There are two ways how you can perform this block. One, you could do this by palpating the dorsal artery, and the nerve is just lateral to that, and you want to make sure you inject at two locations. Or you can perform a ring block just around the penile base, but it's important to make sure you're aspirating before injecting. Next block is the pudendal nerve block. So the pudendal nerve is a branch from the ventral ramus of S2 to S4. This block provides motor and sensory innervation to the external genitalia, to the perineum, and also the anal sphincter. This block can be performed using a landmark technique by palpating the ischial spine and injecting, or by using ultrasound guidance as the image to your right, where you can identify the ischial spine and you inject local anesthetic just off of the ischial spine. This block is indicated for uteroplasty, circumcision, TURP procedure, and also to help diagnose pudendal neuralgia. So here's a study that was published by Dr. Okoro and her colleagues at the University of Washington Medical Center, where they performed ultrasound-guided pudendal nerve block for pediatric ambulatory surgery urology cases. So in this study, they showed that pudendal nerve block was non-inferior to caudal epidural analgesia in terms of PACU pain score, the morphine rescue, and also length of stay of the pediatric patients. So pudendal nerve block is similar to caudal epidural, which is often used in pediatric anesthesia. So next, let's move on to ilioinguinal and ilioepigastric blocks. So the ilioinguinal and ilioepigastric nerves arise from the anterior ventral ramus of L1. The ilioepigastric provides sensory innervation to the lower abdominal wall, while the ilioinguinal provides sensory innervation over the inguinal ligament and also the proximal medial thigh. And it also provides sensory innervation to the external genitalia, the scrotum, and the labia. In order to perform this block, you need to be able to identify your anterior superior iliac spine on ultrasound as depicted on the image to your right. I hope everybody can see the image. And this block is done by depositing local anesthetic between the transverse abdominis muscle and the internal oblique muscle. So the nerves appear as hypoechoic structures within that plane. So this block is great for auriculoplexy, groin surgery, and also great for anterior scrotal surgeries. Next, we have the paravertebral block. So the paravertebral block is a block that targets the spinal nerves and the sympathetic nerves as they emerge from the intervertebral foramina. And in the image to your right, you can see where they deposit the local anesthetic. This block is great for PCNL surgery, hand-assisted laparoscopic nephrectomies, and also shockwave lithotripsy. The paravertebral block can be done in two ways, either using a transverse in-plane technique or using an out-of-plane technique. I typically use the out-of-plane technique. However, I use saline to hydrodissect so I can see my needle tip on my approach. Most importantly, when performing this block, you want to be able to identify your transverse process as seen in the image, the ultrasound image to the left, your lateral costal transverse ligament, and also your pleura so you can avoid causing a pneumothorax. The paravertebral space is just deep into the costal transverse ligament. So typically you feel a little pop if you're in the correct space and you deposit local anesthetic. So here's a study that was done recently and published in 2020 where they used paravertebral blocks for PCNL. This was a prospective randomized double-blind study. They had a total of 46 patients, 23 patients in each group. So the paravertebral group and then the control group had saline that was injected. So paravertebral group had a block at T10 and they injected 20 mL of 0.5% bupivacaine. Their primary outcome was looking at intra-op opioid use and also looking at the PACU opioid use. If you look at the bar graph to your right, in orange is the paravertebral group and in yellow is the control group. You can see a significant decrease in the amount of intra-op opioid fentanyl use and PACU fentanyl use. They also showed that there was actually a really significant drop in antiemetic that were given to the patients in the paravertebral group at 30% compared to the control group, which was about 52%. Next is where we're going to talk about the ESP block. So the ESP block is similar to the paravertebral block in the sense that it targets the spinal nerves also. This block is done by injecting local anesthetic deep to the ESP muscles. This block is indicated for PCNL. You can also use it for lithotripsy, and you can also use it for end-assisted laparoscopic nephrectomies. So at our institution, we do perform either the paravertebral block or the ESP block for PCNLs. So this is a study that was published recently in the Indian Journal of Anesthesia in 2023, where they compared paravertebral blocks to ESP blocks for PCNLs. This was a randomized double-blind controlled study. They had 30 patients in each group. They used 20 mLs of 0.25% Marcaine at T10 level, and their primary outcome was actually time of first analgesia. Secondary outcomes included the pain scores after the blocks. They also looked at the time to perform the block and also look at how much analgesia the patients required. So if you look at the table to your left, the time of to analgesia after the blocks was not significantly different between each group. The paravertebral group was 16.6 hours, while the ESP was 16.3. However, if you look down to the time to how long it took to perform the block, there was a significant difference. So ESP took 5.1 minutes, while paravertebral took only about 13.4 minutes. So ESP was quicker. So in this study, they showed that ESP and paravertebral group were equally effective in providing analgesia, but it didn't actually change the pain scores for each patient. So at UVA, we typically do paravertebral and ESP for our patients. So it really depends on the patient's anatomy and also the time you have to do the blocks. Most of the time, we only have a few minutes to do them. So I tend to lean towards ESP, but some of my colleagues do paravertebral blocks for the patients. So in summary, regional anesthesia can be used to provide anesthesia and analgesia for patients undergoing urology procedures. All of the blocks that I mentioned are great for providing reducing post-op pain after surgery, and paravertebral and ESP nerve blocks are equally effective in providing analgesia for PCNL cases. Thank you. So now I'm going to give it over to my colleague, Dr. Gallo.
Awesome. Thank you so much for having me. I'm just so excited to be here. I'm one of the assistant professors at UVA. I'm in two divisions, the cardiothoracic and critical care. And what I love about that is I get to meet my my patients in the pre-op setting, talk about kind of what to expect for the whole experience from the operating room and in the ICU. And my passion has been really improving that experience from a pain management standpoint. And so I'd like to dive into maybe a little bit of some historical factors and really why the time is right to push for regional anesthesia in cardiac surgery. Big picture, this is a painful operation, right? There's a significant amount of sternal retraction that goes on for several hours during these operations. It's a big incision. It's a big undertaking. And so back in 2019, in this really excellent paper from JAMA Surgery, they started looking at ERAS protocols for cardiac surgery, and it's a multidisciplinary optimization. And it was a great start really down this journey. And they really know that historically opioids had been the mainstay post-operative management for cardiac surgery. And really, when we look at our ERAS protocol here at UVA, that was reflected, right? It was a large dose of methadone, the goal being that opioid would last intra-op and post-operatively and really carry that patient through. But, as we look at some of our pain scores and our pain charting, unfortunately, these patients would wake up, they get extubated, they'd be in a significant amount of pain, they'd receive additional opioids, Dilaudid, oxycodone, ultimately get put on PCAs, ketamine infusions, and really turned out for the first night, no sleep, severe pain, and really, going into the morning, rather exhausted, obtunded, and hurting in the bottom line. And so we really are not doing a great job with acute pain, but what about chronic pain? How about down the road? And unfortunately for cardiac surgery, we continue to see really high rates of chronic sternotomy pain a year out from surgery. Some of these risk factors that this paper note, they're not modifiable, but the one that we could really act on is moderate to severe acute pain within 5 postoperative days. How about opioid use after heart surgery? Unfortunately, cardiac surgery is really an outlier here. We have very high opioid use, even a year out from our operations. And that really starts to get people thinking, should we start transitioning away from a very heavy opioid, based anesthetic and analgesic? The proposed idea is one approach would be to minimize opioids and use and implement more regional anesthesia during cardiac surgery. The European guidelines back in 2023, start to allude to this, that parasternal block surgical site infiltration is recommended to help with pain management. And some really exciting, hot off the press, our 2026 ASA practice guidelines just published this month. Note that yes, there is a strong recommendation to be using fascial plain box for open heart surgery based on a moderate level of evidence that we see reduced pain scores and we see reduced opioid use, from these blocks. And when we look at the chest, there are many different entry points that we could intervene on nerves, but I think the one that's really gaining a lot of momentum just for ease of use, practicality, and safety is up here, these PIFBs and the TTPBs. Of course, historically, there was some thoracic epidural use for cardiac surgery, but that risk of epidural hematoma with anticoagulation being on bypass is really just not acceptable in the modern day. And so I just wanted to show, our setup here at UVA. We do a lot of blocks post-operatively on arrival to the ICU. It's a relatively simple setup. These items come all in a pack. And then here's me at the bedside. This is within an hour of arrival to the ICU. We have the ultrasound, sterile glove, gown. And this takes me about 10 minutes to put, four shots in for the PIFBs and really be able to continue the progression in the ICU of waking up and moving towards extubation. This is an example of a patient who gets a block. And this is really what we're looking for, where they come up, they get that block early on, they get extubated, they tell the nurse, hey, I'm not in pain, I'm able to breathe, I'm feeling okay. And they're getting some sleep overnight, which, when we think about delirium, this is a huge component of the recovery process here in the ICU. And so really where I see where we're at in this journey is all about implementation. The blocks work, the blocks are safe, but how do we start to implement them on a wider scale for patients? And so the first question is always when to do the blocks. Do you do them in pre-op? Do you do them in the operating room, but after induction of general anesthesia, prior to incision? Do you do them still in the operating room, but at the end of the case? Or do you do them up in the ICU? And I think an argument can be made for all of these from a practical standpoint, from a kind of a pharmacology standpoint. But at the end of the day, I think a block, administered is better than no block at all. And there's a lot of opportunities here. Who will do the blocks? Of course, the acute pain service. Traditionally regional anesthesiologists are excellent at this, but I also think that cardiac anesthesiologists and critical care, folks should participate and be part of this and really be able to capture patients at all hours of the day, all days of the week, to really continue to optimize that coverage. Whether to do a single shot or a continuous catheter, from a practical standpoint, the single shots are quicker. They're relatively easy to do. And they definitely, get that patient some instant, relief, but they do wear off. And I see, somewhere in that 12 to 16 hour range, whereas the continuous catheters, we run those for 5 days here. They're under our dressing for cardiac surgery, our Provinas. And, patients love them. The nurses love them. I'm really interested in the ability to improve mobility with these catheters to get patients up and walking either on post-op day 0 or 1. And I think that is ultimately where the future is, but it takes time to get the equipment, to roll it out, to train folks. And ultimately, getting buy-in. There are a lot of stakeholders when we talk about these type of things. So, your cardiac surgeons, these are conversations that are ongoing. You go to meetings, you talk with them, you build relationships with them. And they always ask me about sternal wound infection. What I'll tell them is we do not see, sternal wound infections, or we do not see infections in our catheters for AKAs and BKAs. But this is something that we continue to improve. Critical care nurses, my experience is they love these blocks. They're really on board, but they want to make sure that we're rolling it out in a safe way. Fellow anesthesiologists, definitely there is a spectrum of comfort level with blocks amongst cardiac anesthesiologists, critical care anesthesiologists. And so this takes timing, this takes education. And, oftentimes we see that these folks are already pretty overloaded. So if we can find ways to improve efficiency, that's definitely a key. And ICU pharmacy, just making the medications available, making sure that they're available to support us throughout this process. So in summary, I think, when we think of cardiac surgery, it's done to help patients live longer, better lives. And we want the pain management strategy to be aligned with this mission. And so the time is right. It's better care for the patients. It can be utilized in the clinic as a patient recruitment strategy. It gives our residents and fellows training opportunities. It creates a host of research and opportunities and collaborations. It's financially feasible. And at the end of the day, it can be done. And I'd love to serve as a resource and answer any questions, be helpful in any way to continue to roll it out.
Thank you.
Thank you both. Wonderful presentation. Rakesh, any questions for Yabo and Paul?
Yeah, there are interesting comments among our audience. One of the comments is that what are your thoughts on providing regional anesthesia for cardiac cath procedures like TAVRs and electrophysiology and pacemaker implants? Do you have had any experience in that? And one more comment is from the Pin Bansal, who says they do paravertebrals for vascular ring surgeries in pediatric population with great effect. Do you have any thoughts on doing any PEX block or things like that, or in a fascia iliacus for catheterization?
Sure. Yeah, great question. I don't have any personal experience. When I saw electrophysiology, I jumped right to stellate ganglion blocks, and we have rolled that out tremendously with our EP team, more for VT. But definitely, I think there is some opportunities in some of those minimally invasive cardiology procedures to make those patients a little more comfortable with the groin access, for sure. All of this stuff is, it takes time, and takes those relationships building and such. But I definitely think that is another great frontier to look into.
Thank you.
I want to thank both of you guys for joining us on this World Day of Regional Anesthesia. Again, hopefully gives people some thought and creativity about exploring what other options there are available to their patients. There's a variety of surgeries, and obviously they're very uncomfortable, some of them. And I know the PCNLs are extremely uncomfortable for many patients, and sometimes find it frustrating to find good pain relief for them. So having these tools in your armament are really helpful, and I hope people are trying that. But thank you both for joining us today.
Thank you.
Yeah, thank you for having us. I appreciate it.
All right, great. Well, Rakesh, we've got Dr. Jarna Shah waiting in the wings. Let me get her on. Hey, Jarna, how are you?
I'm doing well. How are you doing, Raj? Good to see you.
Wonderful, wonderful. And thank you for being patient. I know we're running a little bit behind schedule, but, again, hard to stop talking about these topics when everybody's so passionate about them. And I feel like I'm holding back myself, trying to make sure I don't ask too many more questions. But they're very interesting. So next up, you are going to be talking about chronic pain management in pregnancy, correct?
Yes.
All right, let's get your slides up here. Perfect. Go for it.
Okay. Well, hey, everybody. My name is Jarna Shah. I am a recent transplant to St. Louis, Missouri. And we've talked a lot about neurology, regional anesthesia, and cardiology and procedures. We're going to pivot a little bit to talk about how we manage pain during pregnancy. This has been a passion project of mine for many years. Here are my disclosures that relate to my talk. And my goals here will be to talk a little bit about the prevalence of chronic pain in the parturient and look at the most common pain states that we may see and look at the evidence and talk about what treatment options we have for these patients. There is this myth that pregnancy in women with chronic pain is rare. And I hope by the end of the talk, I'm able to convince you that it's something we should be paying more attention to. If we look over here at just our general numbers, we have a quarter of the population of young adults who report having chronic pain. We know that there is a predominance for women over men to have more chronic pain conditions when we think of and widespread diffuse types of pain. In general, the stats show that there are about 5.3 million pregnancies a year, with 3.6 million of these going to live term births. So let's look at that Venn diagram, basically. If you have around 60 million women in this young adult range, not even going all the way up to 65, but 18 to 45 with chronic pain and about 4 million pregnancies, we are going to see more of an overlap with this. As we for chronic pain also increase in our population and our maternal age also increase, we are going to see more of these people in our clinics, in the perioperative setting, even as they plan to talk about when they're ready to conceive and what our options are. You can see that the steady trend over the last several decades is a growing number of pregnancies over the age of 30, and by our current measurements, we still call pregnancies over the age of 35 advanced maternal age. So as we see that, and we also have to think about how many pregnancies are unplanned. How many people do we see every day around procedures, around clinic visits, who are just women? And if the number of unplanned pregnancies is nearly at 50%, are we truly counseling our patients about what their options are? Now, interestingly, because of the hormonal shifts during pregnancy, there are some conditions that do improve during pregnancy. There are some that also worsen a lot. Autoimmune conditions can improve with your hormonal shifts, with relaxing, looking at your headaches. Typically, you do see an improvement and a decrease in the number of headaches and MS symptoms. There are a lot of conditions that worsen as well. Carpal tunnel would be an example. The American Society of Hand Surgeons says that nearly 62% of women during pregnancy will experience carpal tunnel-like syndromes, especially in that third trimester, where you have nerve impingement or any type of tenosynovitis. Lower back pain being very common, as well as pelvic girdle pain. And something I want us to also think about is what types of medications do our patients take? What type are taking? There are some old classifications over here that were used before, I believe, 2011, looking and categorizing which medications are safe for pregnancy and which are not, based on the A through D rating. If you think about the medicines that people come in on, there are lots of people on these SNRIs, on these muscle relaxers, on NSAIDs, on all of these medications, and you can see they don't rank favorably on this pregnancy category system from the FDA. The newer system over here has kind of changed the way we look at categorization, to look at overall risk summary, and to look at pros and cons and make the process overall more shared decision-making model for patients and providers. Let's talk a little bit about some of the conditions that worsen in pregnancy and why. So with the increase in lumbar lordosis and your ligament laxity, you have a gravid uterus that is putting more pressure on that lumbar spine, and that increased weight gain too is also adding to that. If somebody has some pre-existing sciatic pain or a lumbar radiculopathy from an impinged nerve or a disc herniation, you can absolutely see exacerbation of those symptoms during pregnancy. And it can be debilitating to the point where people are no longer able to move around without hurting, even anywhere past the second trimester. The incidence can be quite high. Papers will cite that its incidence is just very in nature. The risk factors include BMI, a history of lower back pain in a previous pregnancy, if the parturient has a history of any joint hypermobility, advanced maternal age. And you can see over here a lot is postural changes. But in addition to that, you just have the increase of relaxin, and everything just really kind of worsens just as you're carrying that gravid uterus to exacerbate that type of pain. Pelvic girdle pain is another good example. If you think about the biomechanics of how the body moves and functions, you have an exaggerated pelvic tilt, which means more pressure on that sacroiliac joint, and also pressure on that pubic symphysis too, which can also be a source of a lot of severe pain. We do have a lot of persistent postpartum pain too. We have pelvic pain that continues even 2 years postpartum, and this can be something that affects patients during that 4th trimester, as well as with their recovery in their future. We think about, are they able to participate in society? Are they able to continue working? Or is this pain something that really follows them and prevents them from having a better quality of life and being part of the workforce? I like to think about the 4 treatment arms kind of like the spindles of a chair. And I think that if we look at medication management as well as procedural treatment options, in addition to physical therapy and pain psychology, we can have a more effective treatment strategy for these patients. When somebody is pregnant, there are treatment options we can provide for severe types of pain that are refractory to conservative therapy, medical management, and PT. We can do ultrasound guided blocks, and this is where I think regional anesthesia can really shine. Typically, it's recommended that this is done in the 2nd trimester because of the use of steroids. 2nd or 3rd trimester is preferable for this compared to the 1st trimester. Of course, data is very limited in this, but if you can visualize this under ultrasound, it is better to, according to what we know, it is better to treat the area locally and regionally compared to systemic treatment. In terms of bupivacaine, there is minimal maternal to fetal transfer of that medication, and it is safe according to what we currently have guideline-wise. Looking at the risks and benefits, there are no adverse risks for using corticosteroids like dexamethasone in the 2nd and 3rd trimester. It does not affect fetal lung maturity from what we know. No adverse effects have been reported for using this for a local type of injection. Another type of thing too is an ultrasound guided sacroiliac joint block. We typically do a lot of these under fluoroscopy. Of course, that's contraindicated during pregnancy, but in 2nd or 3rd trimester, if an SI joint band is not helping, there is to do an ultrasound guided block over here. Around the time of labor and delivery, in the perioperative period, the neuraxial type of epidural anesthesia still remains the gold standard for cesarean delivery and just for managing pain. If you have a patient who is a chronic pain patient coming up, it makes sense as much as you can to place that epidural to provide them with a non-opioid based analgesic for the process and the recovery as well. Right now, these guidelines were released in November of 2025, and these are the most up-to-date guidelines we have for management of these patients for OUD around the time of pregnancy. And I've linked that over there with that QR code. And I want to focus for the last few minutes on what you do when a patient comes in with a device. We're seeing this more and more, whether it's PNS, SCS, DRG, all of these things. How does this affect the pregnant patient? What do you do if somebody comes in? And also, what do you do if somebody comes in for surgery and they have one of these implanted devices? This is kind of applicable to both of those situations. So for the pregnant patient with an implanted device, here's a case series that's out of Rush University looking at a sample of 7 patients who they tracked at the time of pregnancy and how their patients' delivery process. A lot of these were cesarean deliveries for other reasons. You can see a lot of repeats. But for the CRPS pathology, you can see the age for implant is quite young. It's a devastating disease, and these are people who are of childbearing age. This is the important part over here that I want to focus on. If you have a patient who has an implanted device, it's important to understand the entry point of those leads. For cervical types of pain for upper extremity, the leads are cervical and nowhere near where you would need to do any sort of regional block. The simulator itself, for the most part,
Thank you, Jarna. Wonderful presentation. Pregnancy is, we sort of think of regional as just stick the epidural in, but there's so much more there.
Yeah, especially when pregnant women come with chronic SI joint pains and you cannot do fluoroscopy and they still need to provide pain relief. So thank you for this amazing presentation. It gives us a new perspective of we can apply regional anesthesia and neuromodulation in this special population.
Thank you very much.
Yeah, and Jarno, looking forward to see you at the meetings, and we'll keep on the conversations when we get there. Good to have you here, Jarno.
Thanks for having me.
Take
Have
care.
a good rest of the session. I'll be watching.
All right.
Thank you.
Okay, so we're just moving along. We've got a lot of good content today. Before we tee up our next section, I do want to mention a couple of things. Our friends at ASRA have been running some surveys that they would like us to kind of share with you guys. So I'm going to put these up here. The first one is if you look at the little up there in the corner, there's a QR code. You can scan that QR code, pause the video and scan the QR code. This one is a survey they're doing on decision making, dogma, and cognitive bias in regional anesthesia. Very much applicable to some of the topics we've had today on, wrong side blocks and patient injury. So I really think that that's a good survey if you want to participate and see what the world community has to say about this conversation. Go to that QR link up there in the top left corner. This second link, I'm going to pop a different one up here. Yeah, it's hard to point at the right corner. You got to get good at that. Here's another one. This is also from our colleagues over at ASRA. This topic is AI in regional anesthesia and pain medicine. It's a needs assessment survey. So I'm part of this AI working group with ASRA, and we're trying to figure out, what does the community need? Do they need information like Dr. Bowens have on basic education of what AI is? Or are we looking at advocacy? Or are we looking at technology collaboration? What is it that the community wants? So have your voice heard. Go to the QR link up there and fill out that survey. And then the last one, this is going to be relevant to a topic we're going to have later today, is on current practices of pediatric regional anesthesia across the world. This is an international survey study. So if you go to that QR link, go to this one on pediatric regional anesthesia across the world. So we really want to help our partners over at ASRA get these surveys completed and hopefully get our voices in America, North America, all South America, all of us that are on this side of the world contributing to that conversation. Rakesh, you want to introduce our next topic, and I'll bring the guests on to the screen.
Yeah, the next session, we entitled it as Training the Next Generation and Delivering Value-Added Care. Education and service are two sides to the same coin, where the central theme is to improve safety, quality, and equity of care in regional anesthesia. How we train regional anesthesiologists, determine those aspects, but also decrease complication rate, decrease burnout, and long-term workforce resilience. So this session mainly focuses on how education and service models have been integrated in austere environments and in low-resource settings, and also talk about how we can better educate our practitioners and thinking about local anesthetic safety dosing aspects. With that introduction, I want to let Raj introduce our speakers.
All right. We have, three esteemed colleagues here, and I'm excited to have you guys all here. Steve, Sweta, and Lucia, thank you so much for joining us. You're going to be talking about global health. I think you guys have, I don't know who's starting and which slide deck we're starting with. So just guide me through and I'll put it up on the screen. Steve, I think you're muted.
I'll be starting.
Okay, so let me put yours up there and go for it. Go ahead and get started.
All right, well, thank you so much again for the opportunity to participate in World Day of Regional Anesthesia and Pain Medicine. I'm Stephen Haskins, regional anesthesiologist at Hospital for Special Surgery, also a big advocate for point-of-care ultrasound. I also serve on the ASRA Board of Directors. And last year, participated with some colleagues at Weill Cornell and HSS speaking about the role of gastric ultrasound, particularly given GLP-1 receptor agonists. I think it was well received. They asked us to participate again as an organization. And, I was thinking about, what should we talk about? And, it's World Day for Regional Anesthesia. Let's talk about the people who are bringing regional anesthesia to the world. I'm very fortunate to have some incredibly impressive and talented colleagues doing important work, helping to lead the charge when it comes to spreading regional anesthesia, pain medicine, and POCUS globally, and specifically to areas that historically have not had access to resources, education, equipment. And so they go out into the world, and the goal is not to just go there and do a bunch of blocks and help with some surgery, but instead to train the local teams to become experts and become self-sufficient in both regional anesthesia and POCUS. And so if we go to the next slide, I'm going to introduce my two colleagues. The first is Dr. Sweta Pakala. She is a clinical assistant professor. She did her regional anesthesia and acute pain medicine fellowship training at HSS. And in 2011, so 15 years ago, she helped to found the Department of Anesthesia Global Health Initiative. And that has allowed us as an organization through her leadership to help expand regional anesthesia around the world, Vietnam, East and West Africa, India. And this is not just the anesthesia department. She's actually developed a multidisciplinary approach to this global health outreach program. And therefore, it's something that is, comprehensive in terms of musculoskeletal care. She also was a founding member and former chair of the ASRA Global Health SIG. So very fortunate to have her. Next slide. Dr. Lucia Lee, local New Yorker, also clinical assistant professor of anesthesia, did her regional anesthesia and acute pain medicine fellowship also at HSS a little bit more recently. But Swetha has been such a powerful advocate for regional anesthesia pain medicine, and Lucia came along and helped to develop a similar sort of POCUS curriculum to help supplement and augment the experience that they're providing in these resource limited settings, specifically in Hyderabad, India. So very fortunate to have them share their experience with us all today, and I just want to make sure that take a moment to say thank you, obviously, to our speakers, the department that continues to support this work, and our involvement in this World Day. Stavros, has advocated for this, and obviously the ASRA team that has led the charge received many very impressive emails from ELSA over the course of the last few weeks organizing, and of course the ASRA team as well. Raj, Rakesh, you guys are doing a phenomenal job, Liz. So I'm going to hand it over to Swetha and Lucia, and thank you again for the opportunity.
Great. So let's see. I'm just going to see if
Which slide deck are you? Is it yours?
Yeah, oh, okay, good.
There
Is
it
that
is.
the one I uploaded? Great, perfect. Okay, that was easy. Thank you so much, Stephen, for that introduction. It's definitely a pleasure to be here to discuss our work in global health from Hospital for Special Surgery. I know we really have a brief amount of time to cover what I consider a very big topic. But in our time today, I think Lucy and I are hoping to introduce the topic of global health and what it means and why we feel it's so important, and then follow to more specifically discuss our global health program, and in particular two initiatives that we started, one in regional anesthesia and one in POCUS. So what is global health? Essentially, the WHO has defined health as a human right. And it's this notion that health should really transcend national boundaries, that it's a global right for all humans. But of course, that's not really what the reality ends up being. We know that the discipline of global health exists because, in fact, there are large discrepancies in healthcare, access to healthcare worldwide. So global health efforts have traditionally focused on communicable diseases, things you hear about like tuberculosis, malaria, HIV. And with all of this becoming evident, the CDC and World Bank recognized that even though surgical and anesthetic services are cost effective and sustainable, a lot of these concerns have been marginalized in the global health arena. And that's when, surgery has sort of been dubbed the neglected stepchild of global health. And with that comes anesthesia as well. As a result of this, back in, I'd say, early 2000s, there was a call from major international organizations to take a closer look at this problem. The Lancet Commission published in 2015 this landmark study, which they entitled Global Surgery 2030. And this was taking a very close look at exactly this issue, what leads to these issues, and what we could potentially do. And the paper really revealed gross disparities in access to safe surgical and anesthetic care worldwide. Just a few staggering facts they revealed. We see that 5 billion people worldwide do not have access to quality surgery or anesthesia care. We also know that only 6% of the entire world's surgeries are performed in the poorest countries, where actually a third of the world's population lives. So you can see that huge disparity in healthcare services. There's a severe physician workforce shortage. A couple examples: in Sierra Leone, there's only 51 doctors for a population of 4.5 million people. So we can look at the solution in three different categories. One being short-term surgical missions, which I'm sure many of you have heard of or even taken part in, which involves providing direct care. The second thing, which we as anesthesiologists aren't really connected to, is NGOs in low and middle income countries that provide improved infrastructure. And then the third, we would call the new model of global health, which are collaborative partnerships. And they focus really on sustainable development, research collaborations, and basically kind of the notion of, teaching someone how to fish is going to be better than, anything else. And so I think that's where we at HSS have focused our efforts. This slide didn't seem to come through properly, but again, in that third category, our work has all focused on these collaborative partnerships where it's really bi-directional, and it's not just us doing the work, but rather it's a real collaborative partnership and relationship between our partners in low and middle income countries. So two of the programs that we started are what we'll focus on today. I will be speaking about our regional anesthesia program, which we called GRACE, and Lucia will then follow and discussing our POCUS program. So here is kind of a more specific description of our framework. One of the things we really noticed when launching these programs and these initiatives was that there really isn't a gold standard or a framework with which to do global health in kind of an ethical and bi-directional way. And so, with the help of Mark Briette, who really kind of spearheaded this model, we created this needs assessment of basically what the needs are at these local sites. And then using that information, created a curriculum for whatever the subject was, and then taught a course, and then basically compared pre-curriculum or pre-intervention data on knowledge and skills and compared it to afterwards. So here is kind of that schematic. On the left side, you see the components of a needs assessment to determine the local site's needs. This is then presented to an expert panel for recommendations on, any intervention. From their recommendation, we would create a curriculum. And prior to that curriculum being taught, a pre-intervention baseline data was collected on the participants we were teaching, both in terms of knowledge and skills. And those, of course, were in regional anesthesia or POCUS. The training was then conducted, then post-curricular data was collected. The goal ultimately is to continue this process until the local providers are independent in whatever subject matter we were teaching, whether it was regional anesthesia or POCUS, and could then continue to teach their colleagues or future trainees. And that essentially encapsulated the sustainability piece. We first launched this at our site in Ghana, in Kumasi, Ghana, and the process we found took from around 4 to 5 years of kind of going through this process until they became independent in the skills of regional anesthesia. Looking more specifically at GRACE, it stands for Global Regional Anesthesia Curricular Engagement. We named it this so that it could provide a framework for anyone who wanted to do regional anesthesia work in the global health environment, and it would kind of provide the framework and tools of how to do all of the assessments that I just mentioned. So this paper that we published describes the implementation of our first GRACE program at the partner site in Ghana. And just a quick look at the outcomes that I mentioned. We looked at, first, we did a survey on the local providers on their satisfaction with the training program. And here the green bars reflect kind of their satisfaction level, which we found to be very high. And then in terms of the kind of the raw data of clinical and knowledge improvement, you can see that the blue represents here baseline knowledge and skill scoring, and the orange reflects the same scores after our teaching programs, which was a dramatic increase. And then lastly, we also looked at the number of peripheral nerve blocks conducted for amenable surgical cases, which we also saw increase greatly as a result of the program. And this just to show you a couple photos from our site in Ghana. After this program, we launched the same GRACE program at our site in India. One of the sort of things we found really interesting in India was we launched this program in 2019. We went twice, and then we had to obviously put the program on hold for 3 years and didn't return until 2024 after COVID. All the bans were lifted, and found that despite just 2 trips, they had really mastered the skills that we taught them because of how useful it was during COVID. So that was kind of an additional benefit we saw. from our program. So with that, I will now pass the baton to Dr. Lee, who will discuss the SPEARS program, which was the teaching of POCUS. Thank you.
Thank you, everyone. I'm going to share my screen and let me just confirm that you can all see my slides. Can you see my slides?
Yeah,
Can I
we
get a
can see them.
confirmation that you can
Yes.
see my slides?
Yep, we can see them. Go for it. Hey, Lucia,
Yes,
can
you
you
can
hear
see
me?
my slides. Yes. When
Yeah,
I
go ahead and
share
do
the
go ahead and do
slideshow,
the presenter slideshow and go ahead.
and you could see these slides, yes?
Yep, we can see the slides perfectly.
Okay, perfect.
Go for it.
Okay, thank you so much again for the opportunity to give this chat. I'm Lucia Lee, an anesthesiologist at Hospital for Special Surgery, and I'm going to talk about a point of care ultrasound training program that we developed and implemented for anesthesia providers in resource limited settings. We called it SPEARS, which stands for Sustainable Point of Care Ultrasound Education in Anesthesia at a Resource Limited Setting. I have no financial disclosures. And we were interested in creating this program because of the benefits of point of care ultrasound that are particularly relevant to resource limited settings. We know that POCUS is a valuable tool for cardiac, pulmonary, hemodynamic, gastric, abdominal, and airway evaluations. And up to 2/3 of individuals in resource limited settings lack access to radiological imaging. We know that POCUS is portable, non-invasive, safe, and relatively affordable compared to other imaging modalities. And we know that a barrier to POCUS utilization in resource-limited settings is having insufficient ultrasound knowledge among its educators. So SPEARS was a collaboration between Hospital for Special Surgery in New York, USA, and Osmania General Hospital in Telangana, India. And the purpose of this program was to pilot a point of care ultrasound training program for anesthesia providers in resource limited settings with the goal of creating a sustainable impact. And we also sought to establish a reproducible framework for implementing POCUS training programs for anesthesia providers in resource limited settings broadly. And the design of this specific program was providing online training didactics for the participants that were done before a 1 week in-person hands-on training session. We did this this model of the online training followed by 1 week in person at 2 time points, once in February of 2023 and once in December of 2023. So similar to GRACE, we conducted knowledge and clinical skill evaluations before and after each of those interventions. So there are 4 time points shown here in this graph that shows that within each participant, there was an increase in their knowledge and clinical skills for POCUS. This slide also demonstrates that the participants found that they were satisfied with the program. We also had participants keep logbooks of their POCUS exams, and we saw that they went from performing 0 exams before the intervention to performing exams on patients, and they described how the exams changed management. I have some photos here of the program that we conducted in India, and we have images here of our lectures and some in-person patient scanning. And so the path moving forward can be summarized with these 3 approaches. So there is a need to strengthen collaborations towards capacity building and sustainable development, fostering the use of validated models for global health work, such as needs assessments and outcomes evaluations, and expanding the research in this field to share amongst the global health community. and we'll take any questions. Thank you so much for the opportunity.
Well, thank you both for joining us. And I don't know if Stephen's still here. There he is. Okay. Thank you all for joining us. Really exciting and interesting topic. And Rakesh, any questions or comments you want to jump in at the beginning here?
Yeah, like when you go to these low resource environments, what are the main challenges? Is it the technology barrier versus what do you normally face as the biggest barrier to implement POCUS or regional anesthesia?
Yes, I can say that for our experience implementing the POCUS training program, there was they expressed that there was definitely limitations in having a formal education in point of care ultrasound, but we know that other barriers are resource limited, such as limited internet access or just even having equipment, the maintenance of equipment. So it depends on, the specific site, but for Tasmania General Hospital, they actually did have decent equipment and equipment maintenance, which was what made it possible to even execute this program. It's a government hospital, so ultimately, the process there was they would have to petition to the government to get certain ultrasounds, and months or even like a year later, they would get it. But once they got it, they were able to, maintain the equipment. So it made it possible to not only continue the regional anesthesia experience that they gained, but their POCUS as well.
Do you also feel that there are certain blocks which are more easier to teach compared to others? Is that something?
I'll just also add, Rakesh, it's a really good question in terms of your initial question. One of the things this model kind of tried to, control for or take into account was exactly what you asked, which are limitations in these settings. Because you can imagine, one of the reasons we're teaching is because it's such a low resource setting. So when we do those needs assessment, we really focus on figuring out what resources they do have, what interest they have, what the staff there wants to learn. It's almost like we did that to try to correct for those challenges, so that we were teaching whatever we could in whatever way and in whatever subject we could that would actually work. Because a lot of times I think people go in and say, we're going to teach this idealistic program, but there's all these challenges because of the resources, and the context is much different than it is here. So that's you really kind of nailed one of the reasons why we thought this needs assessment was so important. Secondly, in terms of the difficulty of the blocks, I think we definitely did start with kind of what we would consider the easiest to learn. We're not doing like lumbar plexus blocks or any like deeper blocks. Again, it was things that the main reason we wanted to teach regional anesthesia is because a lot of times the ORs are limited, ventilators are limited, so you can't really do general. So we tried to figure out ways for them to do upper extremity surgeries or lower extremity surgeries under surgical blocks. And so, for the most part, those were easy to teach. And we found that, these doctors there are just as smart and talented and skilled once they learn the skills. And so I think we really didn't run into too much difficulty with that part. But good question.
One last question for you guys is, we somehow managed to garner the attention of the World Health Organization for this World Day of Regional Anesthesia, and actually they've commented on how important this is. As you guys think about resources that's necessary to expand or to narrow that gap of surgery being the ignored stepchild, what is it that the World Health Organization can do to help in expanding these programs and expanding local education so that they can self-sustain?
That's a really great question. I think honestly where we're at now, and I briefly mentioned this, but I think we really need a lot more research and data to drive these initiatives, because a lot of people have the interest and even the funding. It's just no one really knows how to go about doing it. And so I think help with funding research and programs, pilot programs like this that can really, in regional anesthesia, cardiac anesthesia, we have so much data to show that this is how you should do something, right? But in in global health, rather, it's kind of such a black box still that we need robust data and kind of systematic frameworks like the one we're trying to put out there that can guide people that do have the interest. I would say that's kind of where we really need to focus a lot of energy right now.
Well, thank you all for joining us on this World Day of Regional Anesthesia. I think global health is, as Stephen said, the most apropos topic for this World Day, and for all the efforts that you guys put in expanding regional anesthesia, POCUS, and better patient care around the world. We really appreciate having you guys here.
Thank you so much. It was a pleasure. Thanks, guys.
It was a pleasure. Thank you.
So in line with that, we're going to bring our next guest on here. Let me get everybody sorted. Hello, Dr. Linares. How are you?
Hey, how are you, everyone? I'm really happy for having me here. And it's really exciting for talking about the POCUS.
Well, why don't you introduce yourself to everyone who doesn't know you and tell us where you're from? Again, this is really emblematic of the World Day. We're bringing the Americas to you. Tell us where you're from.
Yeah, for sure. It's really emblematic because it's the first time I think it's Latin America maybe be part of this war. The annual World Day of Regional Anesthesia and POCUS. I'm born in Colombia, but I live in Brazil, and I'm a regional anesthesiologist also, and the currently coordinator of the division of point of care ultrasound in São Paulo Society of Anesthesiologists. And I'm really happy to talk about that. It's really an honor for me. I work with Steve in the ASRA recently, and you're both are good reference for me in regional anesthesia. And I'm so happy again, and really appreciate it all the be part of this.
I just cut out here. We just lost Luis. Hopefully he'll join us back here in just a second. Not sure what happened there. Well, while we have a second here, let me just take a moment to let people know about a couple other things. I think he's joining back here. Hey, sorry we lost you there for a second.
No, that's okay. I think so. That was my connection, but is everything okay? Thank you so much.
No, it's okay. All right. Well, I'm going to put your slides up and let you chat a little bit. So take it away, and there's your slides. You should be able to control those.
Okay. Yes, I am in control. Thank you so much. Well, thank you again for having me. It's tremendously honor for me for be part of this Congress and for talking today about our experience in Brazil. We create the Brazilian expert recommendation panels, and it is really good for this part of kind of the learn or teaching. This is me again. Well, why does this matter globally? Why now POCUS? Because POCUS is clear, practical, and guidance at the bedside helps a team work safely. And when training and resources are really is not the same, no heterogeneous. Obviously, it's basic safety elements. It's simple to escalable frameworks, and the idea is aligned with the experience with other societies. In this kind was ESA, ASRA, and also Canadian Society of Anesthesiologists. This image is really fine because it's so good about thinking about that, because POCUS at the first time for the oldest anesthesiologists is, well, we're going to learn to POCUS about now. Is this kind of tool help us? But well, it's pretty the same the AI. We need to maybe hug and understand a little bit more about that. What is our Brazilian context? The POCUS is present in many ORs and ICU, but the training exposure is really heterogeneous. We have resource variability, because sometimes in some OR, in some places we don't have the device availability, or sometimes we have just one probe, or linear, or maybe convex, and don't have a lot of probes, and the images archiving differ across the setting. This is really good point. We need to work a little bit more. Otherwise, is the high impact, because when you use POCUS for some cases, well, we can use for induction and for a hemodynamic instability or some emergencies also. What was our motivation? What was the reason to try to create a recommendation or Brazilian recommendation? Well, is this one of the logos for the World Regional Anesthesia Day? We want to create a little bit more equity, access, and relief for the POCUS in Brazil. The currently numbers we have in Brazil, in the Brazilian Society of Anesthesiologists, at least 40,000 of anesthesiologists between residents and assistants, and in São Paulo Society of Anesthesiologists, at least is close to 4,000 of anesthesiologists. And one of the motivations for create the first division or preparatory of point of care ultrasound in anesthesiology. In the past, we have some workshops in Brazil, and these workshops create some numbers. For example, we have at least for the GR 2 or 3 workshops. We don't have any other workshops, official workshops in Brazil for anesthesiologists, and we train at least 276 participants. Was more males than females, and maybe the biggest numbers for the participants we have in São Paulo, at least 138 of participants, and the others states in Brazil, we don't have a lot of training, or we don't have a lot of numbers about that, and this is will we be worried about that? What happened in Brazil? We will have the other numbers, a lot of anesthesiologists, and just this small part of anesthesiologists just training POCUS. And the idea that was maybe change the old way and create the new way. What is the new way? Well, the new way was create the Brazilian expert panel recommendations for perioperative point of care ultrasound in anesthesiology, and the idea was pick education, competency, and clinical implementation with that. We did do that. For example, we picked 39 anesthesiologists. We picked 2 Brazilian anesthesiologists practicing POCUS outside of Brazil, 2 associated editors for ESA and ASRA. Steve was one of our help me a lot for trying to create this recommendation, and 1 associated editor of ASRA also. And what was the idea? We tried to divide this document. The first part was about core. What is core? Principles, ultrasound acquisition, clinical integration via AIM, gastric, focus, lung, diaphragm, and access, venous access and arterial access. And the second part was create the expansion, the emergent, maybe the part of our anesthesiologists, we don't have a lot of tools or pretty saying that the other colleague told a lot of resources of a lot of reference for talking about that, but we need to start to talking with that. It was our way, regional and pain. We don't have for example, for advanced hemodynamics, trauma, focusing cardiac arrest, and optic nerve shift and DVT, and we need to talk a little bit more about education also. We use maybe our base for AIM, obviously indication, the good acquisition for these images, interpretation, and medical decision, because we want to improve the numbers and improve the outcomes of our patients here in Brazil with POCUS. We obviously have a different kind of problems with the kit equipment and infrastructure, but the idea is we have to need to a car base or a laptop or tablet or more portable equipment in the OR, because we don't have a lot of ultrasounds here in Brazil. It's not our reality. We have amazing hospitals, amazing center of training, but don't have a lot of portable machines, maybe accessible for everyone. The idea was prioritize the portability, have at least three transducers, and share models between services, because we can learn a lot of for different services here in Brazil or outside of Brazil, and for sure maintains the sterile cleaning, disinfectation, and this kind of fire. We're trying to put this one. The other idea was to create a quick checklist for POCUS in Brazil, because we don't have maybe a certification, but we don't have a structure for this one. And what we wanted to do with quick checklist, for sure, we want to appliance located maybe 24/7. Who cleans? Who do you document? Where do you save your image? Maybe in a PACS, maybe in a repository. Who trains? Who supervises you? Who do you accredit and revalidate the competence? And now we just have the ACA certification, and we have some workshops, but the idea is continue growing up and continue moving between the societies, and maybe more practicing and more training for our anesthesiologists. And we think about the beyond the core. It's no more just the core, the basics, because again, we have a lot of uses in POCUS. And for example, we have a lot of high relevant application. For example, trauma. We have an amazing center of trauma here in Latin America, and Brazil is one of them. Shock or venous congestion or cardiac arrest. Well, you're recently you have the pearls. You have a course of pills, and you have the lecture for pills. And we have here in Brazil a SAVA. It's pretty the same. This is the same idea, but we don't have now we don't have POCUS. And why don't use POCUS in the cardiac arrest? Why don't teach that? Why don't continue advancing about the future? And obviously other target assessment we have with POCUS. But well, how we can do that? We can go to advance at the next steps, where first of all, consolidate the core bundle, and the recommendation stay here for teachers. Okay, this is the recommendation. This we have for around the country, have a lot of anesthesiologists. Why don't use the POCUS? And then the first idea was, okay, we need to consolidate, then expand according with the hospitals and surgical profile. For sure, not all the hospitals going to do the POCUS, but why not? And have a governance, accreditation, a assessment before hyper specialization, and use telementoring. It's pretty the same that the colleagues talked before. Well, I can do that for the telementoring and help maybe more places don't maybe more is no close than Sao Paulo, or don't close in and the big centers. The point here is define a minimum standard of care, and just it supports consist and a responsible practice. Otherwise, we have here the idea is because we have a lot of insufficient training. You see the numbers, you see maybe the structure of our some points that are really weak here in Brazil, but the idea is maybe explore more that, help use more teaching for that, pulling out for the gray zone, and maybe more accreditation and privilege and consent for this kind of POCUS. We're going to that, and documentation, more images, more storage for auditability and quality. The idea is the patients and the other colleagues see these images and improve the images for that. The proposed framework, which include the three parts: at the knowledge, at the psychomotor ability, and the visual and spatial ability. The idea is the competency based in curriculum, for example, with the residents more practicing, and with a longitudinal assessment. Institutional accreditation also is for defining scope, oversight, and governance. Peer review and maintenance of the competency, more training, more helping for the colleagues that we wanted to teach a little bit more POCUS, create this kind of recommendation, is create more literature, more lectures for help us. Equity, for sure, is one of the pillars of the Congress. Access to equipment and trying to avoid two-tier system. The idea is climbing safely. Not the first ball, not the guy is maybe with the kid. Is really the idea is going to structure training, supervision, and logbook, accreditation, documentation, and images, and KI and revalidation for this kind of images we're going to do. Our final message is we learn a lot with this kind of with this recommendation. POCUS is already present in Brazil and Latin America, and look at that. It's a huge country. We need to align language and security. HIN simplifies integration, question acquisition, interpretation, and conduct. Also, start with the core bundle. Maybe start to be more courage, or be more brave about it. Okay, we need to start with POCUS. Why? Because it's just see have a lot of good results, and what to do that with? Maybe start with gastric, vascular, focus, and lung. Also scale with governance, training, accreditation, documentation, and KA, and thinking the equity, access to equipment and supervision in different scenarios. We open for teach a little bit more POCUS. We open for, and the idea is training more anesthesiologists for, with this kind of recommendation, help us for, okay, this is, we're going to start here, but the future is beyond, and guide and practice based in national and international recommendation that we have at now. This is the group of the team group that helped me a lot with this kind of recommendation. And that's it. Thank you so much for having me here again.
Great, Luis. Thank you. It looks like you have some fans too. I was going to show some of the comments. Some people celebrating you. I'm not sure if these are colleagues or people that you've influenced. So people are watching you and appreciate your comments out there.
Yeah, I see that. It's really good. Know about that. Have some fans, but it's just for work. It's the people that it's the people that are close to me that know we work hard with this part of teaching in Brazil, because we have a tremendously anesthesiologist here. I really have some of them have a practicing outside of Brazil, doing training and come back. And what happened with the POCUS? One of the reasons when I live in Canada and come back to Brazil was, okay, what happened? Why is no POCUS our reality? POCUS is really help. I love regional anesthesia, pretty the same than you, but what happened with the teaching POCUS here is just few numbers. We have a lot of anesthesiologists. What happened? What is the next step? What did they need to do for change our mind?
And I think that what you've demonstrated is that you can have passion, you can have enthusiasm, but until you have infrastructure, it doesn't sustain, it doesn't grow. It just is one or two people that are excited. But until you figure out the structure and the formula for how to propagate it, that's when you really get momentum, and that's really when the growth becomes sustained.
Yeah, for sure.
One of the main reasons regional anesthesia is currently so popular is because it became mainstream. It became part of the core curriculum of training for residents and fellows here. So I think that needs to happen with POCUS too. It has to be curriculum.
I agree totally with you. We need to create a POCUS with a big part of the residence training. I'm really happy for the society, Brazilian society and Paulista society, maybe hug my idea and okay, we need to change. This is the good point at now. We're trying to put in a little bit more exposure, our residents, our anesthesiologists. And in this document, I pick a lot of anesthesiologists around Brazil. It's not just one state. It's a lot of and outside of Brazil, and for sure some mentors, internationals, and was Steve and was Josh Zimmerman was really good, because it's the idea. It show us, well, maybe this have your week. You are weak in this point. You need to evolve in this point, because when you stay here, you just see your reality. But sometimes the other scopes really is really good for help us.
Thank you so much, Luis. We're really excited to see about all the stuff that you guys are working on. Hopefully we'll see some of this stuff presented at the meetings, ASRA, and I think the Latin America is going to be hosting the international conference in 2027. Yeah,
Yes.
so we're excited about joining you guys in South America soon. So thank you so much.
For sure. You're totally welcome. Thank you so much.
Great. Have a wonderful day.
You too. Thank you so much.
Before we get to our next group, I do want to put a couple of little promo things up here for ASRA. We do encourage you guys to become members. Let me put this up here. Membership has great benefits, and it's just growing over time. So we go to asra.com/benefits, and you can see more about membership benefits. We encourage you guys to go be part of the organization, be part of the community, and really help us expand and grow our influence around the world. In addition, one of the things that we're adding is this new learning module system. A lot of our educational content is going into this new service called Edge. It's ASRA Edge, and we're going to have CME content, CME credits, webinars, on-demand courses, stuff from meetings, and all kinds of stuff is in this learning management system. So if you're a member, you get access to this for free. If you're not a member, there's some a la carte options in this as well. So go to asra.com/edge for this. Another one of our amazing media contents that we're putting, we have a journal club roundtable specifically designed for trainees. This happens every quarter, and the next one's going to be in February. So go to asra.com/events. You can find out about how to participate in these journal clubs. And then I run the monthly ASRA webinar series, and our next session will be, it's every Tuesday. It's the second Tuesday of the month at 4 p.m. Eastern time. The next one is going to be on aromatherapy for pain and anxiety. So you can register. You do have to register to watch it for free at asra.com/webinars. Afterwards, the content goes into that ASRA Edge, that learning management system. So you can watch those on demand after the fact. So just a lot of stuff that we're doing as a society. Always like to share with the people. People don't always know all the content that we're creating, all the great stuff we're doing for the community. One of the really, really potent parts of our community is our medical students, residents, fellows, and it's represented by our resident fellowship committee. And we have some representatives of that committee here with us, and just want to bring them along. Alejandro, I don't know if you have your camera on. There we go. Perfect. And they're going to be presenting a topic for us. Thank you for being patient with us, guys. We're running a little bit behind, but we really appreciate it. And there's always some fun technical difficulties along the way when you're doing live streaming. Brittany, I think once you joined back on, we may have to share your slides one more time so I can get them on the screen. You guys are going to be talking about maximum local anesthetic dosing, and we're going to let you take that over right now. So welcome.
Thank you very much for the intro, Raj. And hello, world. My name is Dr. Brittany Bungart. I'm part of the RFC, as mentioned, and I'm here with Dr. Alejandro Halacrasca and also Dr. Alyssa Chen. We're very excited to be presenting this topic on behalf of the ASRA Resident and Fellow Committee. Go ahead, Alejandro.
Okay. Good morning, everyone, and thank you, Dr. Bongard, for your introduction. So before we dive into local anesthetic dosing, I'd like to briefly highlight the ASRA Pain Medicine Resident and Fellow Committee. The RFC is the training leadership arm of ASRA. We bring together residents, fellows, and medical students interested in the full spectrum of pain medicine. And we focus on education, mentorship, research, and national leaderships. So if you're a trainee or known a trainee who wants to get involved in the ASRA Pain Medicine mission, we'd love to have you join us. Applications are accepted year-round on rolling basis. And even if you are not applying, please come meet us at the upcoming ASRA Pain Medicine spring meeting in Arizona. Dr. Bongard is going to continue with the topic.
So why would we choose this topic for this short 15-minute presentation? And I think from a training level, this is something that we're tested on and also taught, at least in the United States, and I imagine across the world. From an international standpoint, though, speaking of the WHO, the World Health Organization essential medications list includes bupivacaine and lidocaine. So these are very important internationally. If you look at this diagram here, and you were actually able to zoom in and read it, you would notice that the backup to interlipid is ECMO. And so if you're in a resource limited place in this country or other ones, knowing what you can give and how, where and how much is very important, especially to make sure for patient safety. Go ahead, Dr. Chen, or Dr. Hello.
Okay, so to start, we're going to talk about what are the maximum, like the different maximum local anesthetic doses that we can find in different popular references. So in this table, we summarize recommendation across 4 commonly used references: Miller, Barash, UpToDate, Open Evidence, NISORA, and also Open Anesthesia. And what becomes immediately clear is that while we often talk about a maximum dose as a fixed number, there is some meaningful variations depending on the source. So if we see bupivacaine, there is this one has a much tighter agreement across different sources, around 2.5 milligram per kilogram without epinephrine, and around 3 milligram per kilogram with epinephrine. This reflects that there is a shared recognition that bupivacaine has a relative narrow safety margin, and there is little tolerance for deviation. But ropivacaine, the story is a little different. Miller and Barash provides a range, while UpToDate often present a fixed conservative safety dose. Kind of shifting the teaching, moving away from theoretical upper limits towards a more toxicity-focused threshold. At the bottom of the slides are other two resources. NISORA emphasized that maximum dose tables from text have limited clinical utility by itself, but because the systemic absorption is going to vary depending on the blood type, injection type, technique, or different additives that we can use, meaning that a maximum dose is only meaningful when we are talking about a specific context, a specific nerve block or clinical context. Open Anesthesia, that is also a popular source about between trainees, mirrors UpToDate and takes a similar conservative approach, emphasizing toxicity prevention rather than procedure-specific dosing. Dr. Elisa is also going to continue with the rest.
Thank you. Yeah, so we see a lot of the variability that was mentioned in package inserts
It's
as
kind of
well.
hard to hear you, Dr. Chen.
Can you hear me at all? Okay, I'll just speak closer. Thank you. So we see a lot of the variability with package inserts as well. Looking at bupivacaine, we sampled the information from package inserts from 6 different countries across the world. We were limited by what we could access, though.
I'll notice, sorry to interrupt, Dr. Chen, but I can't actually hear you. And I know others can. I know that I'm controlling the slides. So I may not be able to go forward.
I'll just raise my hand whenever you should. Oh,
Brittany, I can hear her. I'm not sure why her audio isn't coming to you, but I can advance her slides when necessary.
And I can hear you, Raj. Yeah.
Okay.
Thank you so much.
Okay. Thank you. So bupivacaine, we have 6 inserts found from different countries, but we were limited to what was accessed through an English search engine, Google. Next slide. So among the package inserts that reported a daily maximum, there's a consensus that the value is 400 milligrams in 24 hours. However, next slide. Aside from the daily maximum, USA reports on average higher maximum doses for use in specific contexts, such as field blocks and major nerve blocks, while Brazil has much lower maximums. Next slide. There's also variability in the maximum dosing for major nerve blocks for surgical anesthesia. Some inserts separated maximum doses based on type of nerve blocks, while others did not. Oops, sorry. There's also variability for ropivacaine, as we can see on the next slide. We were able to gather data from 5 packaged inserts from across the world, but again, the data was limited based on what was able to be accessed through an English search engine. Next slide. Among the package inserts that reported maximum field and peripheral nerve blocks for analgesia, there's consensus for 200 milligrams and 20 milligrams per hour, respectively. Next slide. There's also some consensus for maximum major nerve blocks for surgical anesthesia, with 4 of the 5 countries reporting 300 milligrams. Next slide. Interestingly, unlike bupivacaine, there's more variability to what is considered the maximum daily dose. And for bupivacaine, there's also a separate daily maximum reported for epidurals. Next slide. And finally, there's a lot of variability to what is considered maximum field block doses for surgical anesthesia, with only 2 out of the 5 countries reporting the same value. I'll hand it back to Dr. Bungard now.
Brittany, you're back up.
Perfect. Thank you so much, Dr. Gupta, for helping with the technical glitch. So it's great to be able to see these different additional recommendations from the package inserts. What do our local anesthetic dosing say from our expert guidelines? Well, if you look on the various societies, there's no current adult guidelines from ASRA to date, but what is recommended, especially from the last guidelines, is to always consider a minimum effective dose for your local anesthetic. There are pediatric dosing published through joint guidelines published by Dr. Suresh, though. And just briefly looking at that as a summary, besides at-risk children that are less than 2 years in age, this is what's reported as the recommended maximum dosing for single bolus blocks and continuous infusions. One thing you may notice is that 1.5 milligrams seems to be pretty low compared to what Dr. Halo-Kraska had mentioned, and also what Dr. Chen had mentioned. That's why Dr. Sweet, Boretsky, and Beard had actually done a letter to editor in reply to this to note that in practice, dosing, even in peds compared to adults, is also high. And here you can see in comparison the dosing where a single bolus is recommended at 3 milligrams per kilogram across all types, and continuous infusions between 0.4 to 0.5 milligrams per kilogram per hour. And this is for both ropivacaine and bupivacaine. There's a common clinical question that we think about too with max dosing, which is after you give a maximum dose, how much can you give and how soon? And based on this common clinical question that many of us encounter across the world, this prompted the work that myself and Dr. Jay and Dr. Fede Place have published in the last year. To assess this, we looked at the pharmacokinetic data and all the literature and extracted that, which is what a lot of the max dosing that Dr. Halo-Kraska had touched on are based on. And we looked at what some of the continuous and intermittent infusions that are highly dosed are done in practice. And those that we looked at were paravertebrals and TAP catheters. Of note, in these infusions, no cases of LAST were reported, but a caveat may be that that might not have been monitored or have been presented in that data. But we presume that there was no cases of LAST, and thus these intermittent bolus continuous infusions were of a safe dosing range. These are very complicated kind of graphs, so I just want to point out here a few things. This pharmacokinetic data, based on the slowest eliminators, here are the solid red lines, is the average of that data from the pharmacokinetic data. And you'll see then here also from the real world dosing for those intermittent bolus, that the median for those infusions run just above and very close to the slowest eliminators of the people who may be more at risk for repeated dosing of local anesthetics at max dose. So these are complicated pictures. What about just boiling it down to a table? And so we did that for some rational redosing recommendations for pivocaine and bupivacaine based on this comparison between pharmacokinetics and real world dosing. And of note, this is based on healthy adults. We do have weight base, in parentheses is for a 70 kilogram healthy person. This is based on ideal body weight. And the safe redose is based on the median slowest elimination, or the pharmacokinetic data, while the danger threshold listed is based on the upper quartile of the average elimination. So maybe if you've got somebody healthier, you might be able to push the limits a little bit. Dosing presumes that there are no other sources of local anesthetics. So if your surgeons are also giving or another team, consider that in your dosing. Well, how does this compare then to what Dr. Sweet, Boretsky, and Beard said? And actually the 1 hour dosing for the danger threshold kind of falls near to that. Always consider your at-risk populations and look at these references. Can there be an app for that? Yes. And a lot of the experts in this field actually recommend Johns Hopkins app, Safe Local, which includes epi, comorbidities, local anesthetic mixing, and remaining dose. The caveat here as a warning is if you put an extreme high weight up, that the doses are by total body weight. And as you can see here, I put in a very high weight for the calculation, and it said that I could give 125 milliliters of 0.5 bupi, which would not be recommended based on the package inserts. In conclusion, always think about that minimal effective dose, especially because, as you can see here on the right, showing the pharmacokinetic variability in patients, even for Rupi and Bupi, there's no clear absolute answer, and it's patient dependent. So sorry to give you a bored answer of it depends. The current last guidelines that are being joint between multiple societies are currently in process and will actually be including dosing for adults in the recommendations. Thank you very much for this opportunity to present this topic.
Thank you, guys. Wonderful presentation. It's actually quite a difficult topic because, as you mentioned, the pharmacokinetics are in the body are very different than the dose that you deliver in a syringe. So, Rakesh, any questions for our wonderful trainees? By the way, grace under pressure, when technical difficulties occur is a good sign of excellence and expertise. Well done, guys. Managing and rolling with the punches.
Yeah, and first and foremost, I was texting Raj there that the future of the specialty is very bright. We have really great resident and fellowship committee members coming and presenting in the World Day, and that to an interesting topic. Brittany, I have been following your work on local anesthetic dosing along with whatever you published with Guy and Michael. Great work and good job.
Yeah. Well, Michael's watching. Hello, Michael, and thank you all very much. And everybody who's
Michael.
watching, if you have mentees, don't forget to nominate them for the RFC to join us. We are always looking for members to push the opportunities for the community.
Do you have any thoughts on all these local anesthetic dosing patterns being published mostly on long-acting local anesthetics and not so much on shorter-acting local anesthetics? What is your take on it? Like lidocaine infusions through fascial plane blocks and things like that.
Just to understand, you're asking about why there's more long-acting versus the shorter?
And if there is any guidance for shorter-acting local anesthetics.
I think you're touching on a point that's actually trending very soon based on Dr. Fetty Place's recent publications. We're actually seeing an increase cases of LAS and lidocaine uprising, whereas the longer ones we're getting, because there's been more and more data coming out on safe dosing, the serious LAS cases are going down, at least trending down from Michael's work. And I think that lidocaine infusions and the shorter acting ones are going to become more of a hotter topic in the literature.
Okay.
Yeah, I've actually had more trouble with mepivacaine toxicity than I've had with Bupi, Ropi, or lidocaine ever in my career. Mepi dosing can get out of control really fast if you're not careful, and partly because it comes in higher concentration, and you start forgetting about the volume. You're used to larger volumes when we're doing peripheral nerve blocks, and then all of a sudden you've given more than you intended. So some of these you have to be really careful. So last question for you guys is, and this may be out of the scope of this conversation, is what about mixing of local anesthetics? How does that complicate the issue?
Dr. Chen or Dr. Halak-Roscoe, do you want to give a shot, or I can also answer?
So from at least the books and literature that we use for teaching, the common consensus is that most of the doses that we use are not supposed to use when we are mixing different local anesthetics. So I think there is still more, we need more data about what is exactly the amount that we can give when we're mixing different types and different components in different nerve blocks. But at least most of the sources mention that we shouldn't use the maximum dose. So we still should try to use the minimum clinical dosing.
We also published a recent meta-analysis, like mixing short and long-acting local anesthetic did not give us sufficient advantage compared to long-acting only, at least for the upper limb blocks. There may be scenarios where mixology may help, but it only confuses calculations.
That's a good point. And the Johns Hopkins app that we recommend, it does take into account mixing, and it does it by a fractional reduction. So if you get 50% of one, you can get 50% of the other, is kind of like how it's currently recommended in the app.
And I think there's, not that I advocate this, but I think there's a really interesting video rolling around online of our good friend Jeff Gadsden at Duke doing some self-administered block experiments where he blocked himself, or had one of his people block him, doing some experiments with plain bupivacaine versus a mixed dose. Interesting video nonetheless, but very an N of 1 controlled experiment to demonstrate the impact that he saw. So anyway, thank you all for joining us, and I'm gonna reiterate Brittany's advocacy for the RFC. This is a fantastic committee within ASRA, and I highly recommend that if you're a trainee or you know trainees, med students, residents, fellows, come join the RFC. Be part of that conversation. This is our pool of people, like Rakesh said, this is our pool of people that people higher up are looking to kind of pull from for the next generation of activities that we're doing within the society and the community at large. So be part of that. I think it's a great, great group to be part of. Thank you, guys.
Thank you.
Glad we could be here today. All right. Well, we are going to change pace a little bit. Rakesh, I don't know about you, but I kind of feel like I'm sprinting a marathon here.
Yeah.
And so we're going to kind of take a breath of fresh air from our colleagues in your neck of the woods in Palo Alto.
I don't know any of these people.
You don't know any of them? I think I've seen one or two of them before. Hey, guys, how are you?
Great, great. Yeah, thanks for having us, Raj. Thanks, Rakesh. Yeah, great job moderating the World Day events for ASRA. I hope our audio is coming through okay.
Yeah, you sound great. Yeah, and you guys are going to be talking about, actually, Rakesh, why don't you introduce this section of our World Day, and then we'll let Ed introduce his panelists, and then let them take over the conversation.
Yeah, this is a couple of panel sessions back to back, mainly as a more of a fun interactive session, and I'm a big follower of Ed's work throughout my life. So this is like to learn how he has made education fun and more relevant. So yeah, I'll let Ed lead the talk and introduce his speakers and lead the way.
Well, fantastic. Well, thank you both, and thank you so much to the organizers of the ASRA World Day events, as well as to ESRA, really, for pioneering this concept of really bringing regional anesthesia education across the world. So we're very fortunate to participate. I'm very excited to share some of our thoughts. As Raj had mentioned, we've tried to incorporate a number of different interactive types of sessions that hopefully take a break from some of the more didactic related presentations during all of these different World Day events. And I'm joined with some fantastic faculty here at the VA Palo Alto and Stanford University School of Medicine. Some I've known all of these people for many, many years. I've known Raj, I've known Rakesh for many years. And I think that it's always fun to get people together who are really passionate about what they do professionally, because I think it really helps to reinvigorate your interest, I think, in doing what really makes a big difference for patients, and it really helps, I think, hopefully keep you excited about your career. So I'll introduce people briefly from starting on my left, moving on down the row, and then I have some questions. I'll serve as the moderator, and I'll be asking questions to our panelists, and then hopefully if you all at home have specific questions for us, then I encourage you to put those into the chat, and that way Raj and Rakesh can help us moderate more of a discussion. But to my immediate left is Jody Lang. She is currently the program director for our Regional Anesthesia Fellowship at Stanford. She also serves as one of 2 counselors for regional anesthesia that represents the specialty of regional anesthesiology and acute pain medicine nationally within our Association of Anesthesiology Subspecialty Program Directors. And then to her left, we have Mariam Sarwari. And Mariam is our Associate Program Director of the Stanford Regional Anesthesia and Acute Pain Medicine Fellowship. She also serves on the Board of Directors of the California Society of Anesthesiologists, and so definitely an up-and-coming leader in advocacy as well as education. And then to her left, we have Tony Maki. Yeah, Tony is an incredible. I've actually known Tony for many years. Yeah, so he, after finishing his fellowship in regional anesthesia and acute pain medicine, he went on to become the division chief of regional anesthesia at the University of Texas Southwestern in Dallas, Texas. And then, after doing that for a number of years, as an educational as well as a clinical mentor, he went back to training to do pain medicine fellowship. So he currently is one of only, I think, 2 faculty that I know of offhand that actually serve within both of our divisions of regional anesthesia as well as our division of pain medicine. medicine. So between these three, we have years and years and years of incredible educational experience. And I'm going to jump right in and just ask some questions. So as some of you at home may know, fellowship training in regional anesthesia and acute pain medicine in the United States is a bit different than other parts of the world in that we do have a standardized program. We have curriculum requirements that are already written for accredited programs in regional anesthesia and acute pain medicine that are applicable across the country. And as part of that type of a system, as you can imagine, there are various elements that have to differentiate fellowship from core residency training in anesthesiology. So I'm going to ask Jody first the first question. So how would you describe the current state of residency and fellowship training in regional anesthesia within the U.S.? And what additional skills do you think that anesthesiologists gain by doing a fellowship?
Thanks for asking, Ed. I'm gonna throw out a caveat that I'm occasionally glancing at my phone because I'm on regional call today here at the VA. So like I turned it on silent, but that means I have to look down every now and then. What is the state of regional training for residents and fellows in the U.S. right now? So I think resident experiences are like somewhat similar, obviously with a lot of differences. There's a lot of residency programs out there. But in general, my experience talking to a lot of residents over the years, a lot of applicants to our fellowship program over the years, generally most residents in the US are going to do like a dedicated regional anesthesia rotation, probably CA2, CA3 years. Some, I would say lucky residents get to do a more longitudinal experience totally depending on the program. At Stanford, we have a lot of ground to cover, a lot of places, a lot of locations to cover, and we have a lot of residents. So our residents do a dedicated rotation, usually CA2 or CA3 year, and then they have an option for like a 2-week senior elective. I would say that's actually relatively standard, relatively typical. Fellowships, so we have 60 plus ACGME accredited fellowships in the US, and then if you look at the US and Canada, there's close to, I think, 80 fellowship programs in regional anesthesia and acute pain medicine total. And there's a wide range of training among all of those programs. So it really does come down to, I think if you've interviewed or you've like seen one program, then you've seen one program. Every place tends to do things a little bit differently. With that being said, all of us that are ACGME accredited are meeting those standards. And so it's pretty specific actually, like what all ACGME accredited programs are required to do. Every program's doing that in their own way. And then there's a lot of non-accredited programs too that are maybe like a little bit more variable in terms of how much time you're spending actually doing regional anesthesia, or how much time you might be just like working in the OR as an anesthesiologist. Question 3 was, what do we get out of fellowship?
What do you get out of fellowship?
Oh my gosh, so much joy, so much mentorship. I think, obviously I think about this a lot as a program director, especially now because we know what the job market looks like in the US for anesthesiologists. And so folks that are applying for fellowship really want it, which is awesome. I mean, I think all of us really wanted it because it's still an extra year of training that we all chose to go through. I think one of the special things about fellowship, and this I learned from one of my favorite faculty members when I was a fellow, Ryan Derby, if you're out there. He taught me pretty early in fellowship that like it is a luxury to be able to do a fellowship. It's a luxury to spend a year learning about this one thing, you know, that you're really interested and excited about, and you get to spend a whole year just diving deep into this one specialty, this one aspect of your career. And I think what we learn as fellows and what we try to teach our fellows is like, I think what we get across to our fellows is subtlety. It's not only all the big picture stuff, obviously you learn how to do blocks, like people are already good at blocks by the time they get here. You learn all the people management, you learn communication, and you get all the extras, the didactics and the educational opportunities. But I feel like something that you can't learn on YouTube, you know, when you go out into practice is the subtlety of technique, the subtlety of like choosing an approach, the subtlety of like how to approach a service, how to approach not just giving good care, but giving excellent care. And I think that is what you get when you choose a fellowship. You get expertise and excellence, and then you learn how to teach expertise and excellence as well.
Right. Yeah, thank you, Jody. And I'll pass the next question down to Miriam because we know, as we all know, not everyone does a fellowship in regional anesthesia and acute pain medicine. I wish everyone did because it's such a great and unbelievable facet to offer your surgical care. It's just the experience, the outcomes for patients are so different. But I know that worldwide, I mean, we have a problem in that regional anesthesia is still underutilized, and so a good bulk of our education still has to be focused to trainees who will not do a fellowship, to our graduates from anesthesiology residency who go out into practice and hopefully can still utilize many of these techniques for all those deserving patients out there. And I know it's not just a problem in the US, it's an issue worldwide. So as an educator in regional anesthesia, how do you design a regional anesthesia rotation or teaching experience for residents that whom will go into general practice, or who may even go into other subspecialties, but may have use for regional anesthesia in the future?
Yeah, that's a wonderful question. And I think it first starts out by getting a sense of what are the private practices that most of our trainees go to? What do they look like? So being in contact with a lot of my co-residents and colleagues who are in private practice, what I've seemed to pick up is that the trend for use of regional has increased. And one reason being that a lot of these new surgeons who are joining these private practices trained at academic programs that had regional, which is a big shift from a while ago when some of the more senior surgeons didn't necessarily utilize regional. So now you have new surgeons coming to these private practices who utilize regional, and so they expect to come and have their anesthesiologists do blocks. And so keeping that in mind with the new generation who, that's one of the first questions I ask when our trainees come on rotation is, what do you think you're going to do after you graduate? And if I find out that they're going into private practice, then we really focus on a couple of things. The number one thing I always tell residents, do no harm. So we focus on where not to go. One of the biggest things to really focus on is the vasculature. How do you make sure that you don't cause any harm to the patient? And then after that, big picture, how to have a successful block. Because I think the longevity of regional at any private practice is having a efficient and consistent kind of block pattern. So you really want your trainees to get good at offering good blocks without causing harm. And so we start general, with the adductor. We don't go into the technical, getting exactly past the certain membranes and get circumferential coverage of the nerve, as I usually like to do. We start big picture. How do you get subsartorial, injector local, and get a good block? So big picture items, the amount of time our residents train with us is very short, in my opinion, which is another plug for why I think a regional fellowship is the way to go, even if you do end up at private practices. Having more opportunities to block, it's not just kind of knowing the anatomy and how to needle, but it teaches you, and these are things we talk about with our fellows all the time, efficiency, time management, not delaying the room, making sure communication with the surgeons is adequate and everyone's on board. So I would say, figure out where your trainee's going. If they're going to cardiac, we try to send them more to do the cardiac cases, the ESPs and the serratus anteriors. But knowing where they're going and having big picture idea of how to have successful blocks is kind of where we start.
Yeah. I think that's a really important perspective, is that being able to offer regional anesthesia, which we know has such incredible direct, observable, measurable impacts for patients. It's a real, in many ways, I think it's a real feature to offer a practice. And I think that we've heard from so many of our colleagues who are in private practices, foundational practices, as well as academics, that that having that skill set of being able to bring consistency of reliable regional anesthesia techniques it's of value, and it's also highly sought after. So definitely, for trainees who are out there, I think that really trying to focus, as Miriam mentioned, on kind of those core techniques that you can deliver very well in very high volume, especially those that your surgical colleagues have come to expect in their training, I think is super, super high value. My next question is for Tony. So I think Tony has this incredible, very diverse career experience already, because having been in a role where you've been a division chief for regional, have run a fellowship program, and then now have completed pain medicine fellowship and now boarded in pain medicine. I think that it's taken some time, but I think we've seen in recent years that we have had a much more blending, I think, of clinical practice, research, as well as education between regional anesthesia and pain medicine. But I think that you have a unique perspective. Yeah, how do you see having those two fellowships? Yeah, how has that complemented your own clinical practice, your own interest in academics, as well as how do you think that it's changed your perception of your role as a consultant physician?
Thank you. Yeah, I think on the one hand, the kind of more forward aspect of that would be the depth and breadth of knowledge and skills and the intersection between the fields, and that there's a lot there. And that's kind of what I expected as I made my transition. What I thought, or what I now kind of realize as I am transitioning in my practice and having it yet still balanced, is that the more unique aspect, as I look in hindsight, is actually the human aspect, and understanding more deeply the arc that the patient is going through of their experience and their human experience, and how I can leverage what I understand and can connect with them, whether that's as a regionalist, if I only have brief moments to meet them once, or during an acute pain service where I get to see them maybe multiple days, but not long term, or separately if it's in the pain clinic and I have a more longitudinal experience, but that each of those moments is very important. And we have a unique opportunity to make a difference with our skills in each of those different moments. So I think that's kind of where I've taken it, where I continue to go with it.
How do you bring that perspective to your trainees? Because I think that they too, sometimes they're just so very focused. Like when you're attending on the regional service and versus when you're attending on the acute pain service in the hospital versus when you're in interventional pain, I can imagine that the perspectives, the priorities of the trainees may differ. So how do you bring that insight to them, especially in those moments?
I think it's looking for those moments and looking for the pause when maybe I noticed that they noticed something. And maybe there isn't the time, let's say, during a regional procedure to discuss it right then, or appropriate perhaps, but we can debrief afterwards and reflect on that and talk about what was the opportunity there. Did we capitalize on the opportunity? Could we have done something better with that opportunity? And maybe more separately, when things are maybe a little bit slower, perhaps a pain clinic, there the challenge is to always ask why, to be curious, to understand the individual, understand how they got to seek to understand how they got to where they are in their experience, and to understand, especially in the pain clinic, a little bit different than acute pain, but in the pain clinic, if they've reached you, they're in a real state of distress. And so to understand all the things that they might have gone through to get to that point, like on cue.
Our lights turned off. There we go. There we go. And then we'll shine a light back on you.
Yeah.
But no, I want to call out just something that you said that I think is really, really relevant, and I love it. I hope everyone at home really picked up on it. It's this idea of the pause, because I think we have so many pauses in perioperative medicine. We have this, all of our different checklists, the pre-block timeout, we have the pre-anesthetic timeout, the pre-surgical timeout, but this idea of having a pause specifically to focus on an educational element, I think that's really cool. I hope Raj, Rakesh, I think we'll have to put a bookmark on that, because I think that's something that we're going to want to revisit and really think about how we incorporate that into much of our teaching. I have a question for everyone, but I'm actually going to start with Miriam, because I know, like, for all of us who've been at this for a little while, you realize that one of the exciting things about regional anesthesia as a practicing physician is that you're always learning and trying new things, which is like one of the coolest things that I think about in terms of our subspecialty. Can you tell me, I'm going to start with you, but I want to hear from all of you, what would you say is the most exciting change that you've made in your practice as a regional anesthesiologist, whether it's in teaching or clinical practice, in the last year or so?
That is a great question. I would say the biggest change that has come, and it's been in the form of teaching, has been AI. Sometimes you get questions from residents that take a while for you to, get the answer to, and ChatGPT and AI has decreased that. Sometimes there's images I need and have trouble finding. So I would say AI has definitely changed what the day-to-day regional didactic teaching looks like. It's very easy to input information and then go through what comes out. And for any of our fellows or trainee, other attendings, it's a really nice way to get a structured kind of lecture if you put in the input, and it breaks it down in a very organized fashion. So I'm very happy about its introduction and utility in all of medicine, but especially with teaching.
Yeah, I like that. I like the idea of using AI to tackle some of the things that we don't like to do. Like I saw like a great post on social media somewhere that it was a writer, and her comment was, I really don't want AI to do all this writing for me while I still have to wash my dishes and do the laundry. Like I want AI to do the dishes and do my laundry so I can do all the writing and all the fun things. So so I like that perspective. Jody, can you tell me about one thing? What's one exciting thing that you have done that's changed, maybe a new change in your clinical practice or in your teaching?
I don't know if it's new or if it's old, but like, I think like one of the fun things about being in charge of a program is you get to make decisions about how things look. And I think it's funny that, I don't know, geez, it's been almost 6 years since COVID started, wildly, but I just really appreciate doing stuff in person. I really appreciate doing stuff in person. And I really try to make sure that I want our lectures in person. If we have to do a Zoom lecture, I want cameras on, because I just really value the intangibles of like being together as a group and learning from each other, versus like all the Zooms we're on with our cameras off and we're also making dinner at the same time. So I think for me, it's more of just like an awareness and a focus of like, I appreciate what's happening today. I appreciate what's happening with my patient that I'm standing here in person talking to. And then I try to like design a fellowship program and like educational experiences where we're doing as much in person as we can, because AI is super cool and it's like adding all this technology, but I think we still just like need to connect as humans.
All right, Tony, all right, what's one exciting change you've made in your clinical practice or teaching?
First, just Miriam and Jody's comments both hit home for me too, but to pick something a little different, I'd say for me, being at this crossroads of pain and regional, that the looking for these opportunities of where they meet and how my knowledge would be able to translate both directions. And so one of those kind of ways is always seeking out when are the opportunities that I could be doing a block that might actually be even more specific. So for example, if I can get away from the motor aspect of the central motor nerve and I can make it just a purely sensory block. And because of the nature of some of what I do in the pain world, I am pushed to do that in different ways. And so I seek to bring that knowledge back to the regional world of when do I actually have the opportunity to leverage that. A lot of times we don't, but sometimes we do. And so there, I think it's pretty cool.
I mean, I think I have a very simple one. I just, in the last year and a half or so, I've just, especially for our residents, who have a very brief period of time, working with us to try to safely and effectively perform some of the most like high yield, but sometimes concerning, or at least can be concerning blocks, like brachial plexus blocks. Yeah, I've just started teaching. I mean, it's more of a throwback. I want to credit some of our ASRA founders, like Alan Winnie, who described the brachial plexus sheath. But I teach the interscalene brachial plexus block as a fascial plane block now. And I tell our residents, especially if you're going in general practice, you're going to take care of a lot of patients who are having shoulder surgery. We know that those patients are going to have a lot of pain after surgery, and not to be intimidated by whether or not they can figure out what's the C5 nerve root or what's the C6 nerve root, or what's, where does the suprascapular nerve take off. Just if you approach it as a fascial plane block, the way that Winnie described the sheath, and you can get local anesthetic into the compartment, you're going to have a good block. Your patient's going to benefit. It's also a lot less stressful, and you don't have to keep moving your needle around to potentially hit all the nerves. So my next question,
Hey, Ed?
I think, and I'll start.
Hey, Ed, can you hear me?
Only because I think, I'd like to know, it's because when you get in practice, I think one of the things, for those of us in our generation where, I didn't even learn ultrasound as a trainee. So you're always learning something new. So, one of the things that I think is really critical for lifelong learning is you have to know where to get your information. So Tony, I'll start with you. So what resources do you recommend for physicians in practice who are out and whether they just finished their residency last year or they finished their residency 20 years ago? Where should they go to stay up to date in terms of what's new in regional anesthesia?
Yeah, I'm going to give a very biased response here. So and one of the hats I wear is as vice chair and editor for the ASRA News. And so I'm going to give a plug for ASRA News because I think we have a very high yield, very practical and pragmatic product that we put out. Every issue, and it's a quarterly publication online, every issue we have 6 articles that are focused for high yield clinical practice. And we always have a complement of other articles as well. But they're short, they're concise, they're efficient, and they're great for learning and spurring on more learning. It's not the end all and be all, it's the beginning of your learning journey. And it's really high quality. It's vetted. So written by great authors, vetted by great team. So that biased response, but that's one place.
As a completely biased former editor of the ASRA News, I can also endorse the ASRA News as a great product for continuing lifelong learning. I'll come back to Miriam now. So what do you recommend in terms of resources? And I think this is also very important. I think when we're as educators for our trainees, we know that they are going to find sources on their own. So how have you incorporated that in your practice? Like which resources do you point them to? Yes, because you know they're going to go online for resources anyway.
Definitely. Well, I think for those of us in academics, it's almost a little bit cheating. You get resources whether you like it or not. Whether, for us on regional, we have Journal Club monthly, we have grand rounds. And then for our private practice colleagues, and I tell this to our trainees who are going to private practice all the time, again, a plug in a sense, but interacting with your societies, ASRA, ASA, CSA, whatever it may be, by default opens up resources to you, whether it's the ASRA News, whether it's the ASA Monitor. I mean, just in today's show, for anybody who joined on, they talked about the Journal Club for the trainees. They talked about a webinar series. So just interacting and being involved with your component societies will open the doors to stay up to date, most of all, attending conferences, reading, hearing about the top 10 abstracts for the year. It's also a fun way to keep up to date. So I highly encourage everyone to join their societies and stay involved.
That's right. Jody, what are some resources that you point trainees to? And I'm sure that in many ways, and I'm sure that our friends out at home also probably have the same experience. If you've been an educator, then your former trainees they'll get in touch with you for the rest of their careers. So when people are asking you for information and asking you where they need to go to get the latest resources, where do you point them?
Yeah, I mean, agree with ASRA News. I really do like ASRA. I'm kind of basic. I think just wrap them. It's a great term. Not to say wrap them is basic, but I think it's like it's just like an obvious choice for a regionalist for good reason. I think that's like a great place to see the latest. And I do I guess I'm like on an in-person kick today because I like a meeting. I like to go somewhere and hear a person talking to me and about their latest research or about like on a panel talking about their approach to things. So for me, that meeting is usually, there's like an education meeting I go to learn specific stuff about education and anesthesiology, but then also, plug for ASRA. I'm just like, this is so predictable. I'm sorry. Yeah. I would say the other thing though, I mean, if you're someone who's just gone out into practice and you're like, I don't know what block to do, or this isn't unusual, like you can, you do your Google search or whatever, but like, don't be afraid to text your old attendings. Like we get these texts from our recent trainees, like, thank goodness, that's what we like, and then we can troubleshoot with you. So don't forget the folks who trained you, their job is to train you for the rest of their lives. So yeah, it's another good resource.
Yeah, I think that I think it was a big mind shift for me. I think at some point in the last few years when I just stopped pretending that our trainees are going to go to the same resources that I used when I was a trainee. They're not going to necessarily go to the journals and read the articles from beginning to end, or go to the textbooks. And they're going to get the information that they can get from the most powerful source of information they have, which is their phones in their pockets. And I think it really, shifted my view as an educator to say, maybe part of my job is to curate that information, is to say, in the universe of all the internet-based sources, here are the things that probably are the most validated and worthwhile. And so, like, here we are on YouTube. I think on YouTube, I highly recommend. I think Duke's YouTube page is fantastic. A lot of just-in-time videos. They're done very well. They follow very safe techniques, and they can be performed. You can observe them, just before you're about to see a patient. I recommend, so there's so many high-quality lecture-based YouTube channels as well. I think, at least in regional anesthesia, I look at Professor Kichin Chin and Amit Pawa, Vicente Roques Escolar. It's amazing content, really with some of the same high-quality lectures that they give at international conferences, like all year round. And then, of course, I was telling our fellow yesterday when we were working together that like if I'm driving in and there's a new episode of the Block It Like It's Hot podcast, I'm listening to it. I think Jeff Gadsden and Amit Pawa have done such a nice job of just combining education and entertainment. Their latest episode was one of their interviews from the most recent ASRA annual Congress. And a lot of those conversations, these aren't conversations that we'll necessarily have with the same people ourselves. And so to actually hear that kind of very organic discussion about topics that have relevance to our patients and our practices, I think it's incredible. You're not going to get that information anywhere else. So I think I'll invite Raj and Rakesh actually to come back and join us, just because I think we have some questions and we'd like your input too. So I was going to ask everyone, but you two are included. Since we were on the topic of like former trainees reaching out to you all the time, because that's what they do. What's a question that you recently got from a former trainee that's related to their practice, at least in regional anesthesia? I'll start with mine. I know, like, I regularly get asked from former trainees, just is because in the US, we have this process of procedural coding. So I'm always asked about, well, what code should I use for this, or what code should I use for that? Because not much of our healthcare economics, the state of healthcare economics, is really taught in residency and fellowship. How about you guys?
I'll let Raj go first.
Yeah, I don't know if I think people ask me questions because this is usually what the vein of what I talk about a lot during their training. So they go back and ask me those types of questions. Most of what I get are about, like, how do I introduce a new type of service into my practice? What is it that makes that valuable to that institution or that surgeon, or how do I convince them that it's a good idea? They read about a new block, or they read about something, and then they ask me, like, how do you kind of implement that? That's kind of my bailiwick when I talk to them about stuff during their training program. So I think that's probably what resonates or makes them think of me when they're reaching out. And then, of course, people still, even though we create the apps, people still ask me questions about anticoagulation. So they'll call me, and I'm like, well, just look it up. It's right there. But there's always a gap in someone's in the guidelines somewhere. They managed to find that one situation that wasn't written about, and they'll call me about that.
Actually, that's a good one, because I was citing a paper that Rakesh had co-authored just the other day, because we were talking about the Canadian Regional Anesthesia section's consensus recommendations on bleeding risk using the CIA score. It's like, how critical is it? Is there an intervention, and how easy is it to assess? And that was just such a nice way of taking the ASRA guidelines we have and filling in some of the gray area, right? When you have that patient in front of you that's somewhat complex. Rakesh, what have you been asked by a former trainee
Similar to what Raj has commented, mostly to know procedural aspect of newer blocks, blocks which we did not get an opportunity to teach. More recently, many of my previous trainees have been asking about stellate ganglion blocks, how to do them, because I think it's getting more popular in practice, especially in the cardiac realm, or when they land up in complications. That's when, because that's not the training we do not give in real time. So we talk about all these hypotheticals, but when you actually have a complication, people don't know how to react. People don't know how to manage it because they have never had it in their life, these rare events. So when a patient has a neurological symptom, that's when I get a phone call from my trainee saying, hey, what should I do next?
I mean, I think to Jody's point, I mean, really that is one of the things that you really get from having that close interaction with your teachers and your consultants over the course of your training is you do build up this professional network that you have your whole life, because it is scary. I mean, I think it's not an if, it's a when, and things happen. They've happened to all of us, and we earn these badges over the course of our professional lives as physicians, and it's nice to know that you have the support from someone or many someones just at your fingertips.
So Ed, I'm gonna to wind down this panel. I'm gonna actually share a question from our good friend Jerry Jones, and this is directed towards you. You get to answer this one. If you had more time with fellows, what is the one thing you wish you could add to their range of insight, not knowledge base, transitioning from academic to private practice setting or culture, in particular?
Yeah, I mean, I think Jerry's absolutely right, and thank you so much, Jerry, for the question. I think that there definitely, if there was something that I could try to impart on our fellows before graduation, that sometimes I don't think we emphasize quite enough, is I think it's a bit of a combination of what all three of our panelists have talked about today. It's really that longitudinal perspective, that puts the patient in the middle, but like looks at where you can look at your role as a consultant physician as someone who really adds value to their care. I think that it's very easy to get so overly focused about where you put the needle, or how to get the best view with the ultrasound when you're in a regional anesthesia fellowship. I mean, intrinsically, like it is very technical, but I think that the emphasis, sometimes I think we hear them referred to as the soft skills, but they're not soft at all, right? I mean, they are the most critical skills we can teach a consultant physician, and I think to impart on them, I think how the value that they can bring to the individual patient, to their system, and even as a representative of our great specialty of anesthesiology is something I would love to have more impact on many of our fellows, residents in training, as well as they transition to their practice.
Well, I want to thank all of you guys, Ed, Jody, Miriam, Tony. You guys are always great to listen to. So much incredible talent and insight and knowledge in that one room at that end of the table. Wonderful to have you here. Join us on the World Day of Regional Anesthesia. And I look forward, hopefully, to see all of you in Phoenix for the spring meeting. As Jody says, it's nothing beats an in-person get-together. And as I've always told everyone, I think the best time at these conferences are usually in the hallways. So I look forward to seeing you guys in the hallways and chatting up some more. Thank you for joining us.
You too. Yeah, thank you so much for hosting this great event. It's a pleasure to be part of it. We look forward to seeing you again soon.
All right. Talk to you guys soon.
Thank you.
Bye.
All right. We have one more panel, Rakesh. We're getting there, and our panelists have been waiting eagerly to join us. Let me put them up on the screen. And Stephanie, I hope, will join us here in a second. Oh, there she is. Perfect. Welcome, all of you. This is our panel. Actually, Rakesh, why don't you introduce them here and their topic, and then I'm going to kind of take us off the screen and let them have the conversation for a little bit. Before you introduce, I do want to remind people who are listening, please submit the comments, questions for our panelists into the stream here, and we'll share them up with them so they can attempt to answer them, or maybe look at them after the whole experience. So thank you. Rakesh, go ahead.
Thank you. I know Abhijit since my fellowship days in Canada. Abhijit is a pediatric regional anesthesiologist from London, Ontario. He did his fellowships in Toronto Western, SickKids. Am I right?
Yep.
And he can do the introductions for the rest of the panel. Stephanie is my colleague from Stanford.
Thanks, Rakesh and Raj, and thanks for inviting us to speak in this session. This is going to be a panel discussion, more of an interactive session. Before we go ahead, I would like to introduce my colleagues, esteemed speaker from different part of the US. So I have Dr. Stephanie Spahn. She's an associate professor at Stanford University of School of Medicine. Then we have Dr. Rani Sundar, associate professor, Department of Anesthesiology and Pain Medicine, Seattle Children's Hospital and University of Michigan, Washington School of Medicine. And lastly, you have Dr. Vipin Bansal, assistant professor, Department of Anesthesiology, Emory School of Medicine. And I'm Dr. Abhijit Biswas, associate professor, Department of Anesthesia, Pediatric Medicine at Western University, Canada. Now, our topic today is an interactive session on innovations in the world of pediatric anesthesia, regional anesthesia, and pain medicine. But before we go ahead on what we are now, I want to share briefly regarding how we started and when we started, how we started, where we started, before we go to know what you're doing now. Again, in brief, the journey of regional anesthesia began as early as 1884 with Carl Core, discovery of the local anesthetic properties of cocaine when used in the eyes. Following which, like after 14 years, August Bayer performed the first spinal anesthetics using cocaine in 6 patients. 2 of them were children. All of them had severe headache and nausea, vomiting. And then he tried on his own, on himself and his assistant also the following day. And with a similar problem, they stopped the whole thing. It took at least a decade before the whole spinal anesthetic came into work again. And from early 90s to late 90s, there was a lot of change. We had anesthesiologists introduced at doing anesthesia, not the surgeons. Local anesthetic changes and a way of doing the spinal, everything changes. I'm from Canada. The first reported pediatric patient getting a spinal was in 1933 in Toronto and 1949 in Montreal. In the same year, 1933, the first use of caudal analgesia for cystoscopy was described by Meredith Campbell in the American Society of Regional Anesthesia. Now, thus goes a bit of brief history of how we started, when we started. Since then, things have changed a lot. Lots of evidence for pediatrics, change of local anesthetics, ultrasound, neuromodulation in pain. There's so many things to talk about. So before I go ahead and start anything more, I would like to invite Stephanie and discuss a bit more about what we have changed over the safety over the years in safety in pediatric regional anesthesia.
Thanks so much, Abhijit, especially for the introduction. It's really wonderful to see everyone. This is a huge question. So I like to break it down into really like 4 main factors. And just as an intro, pediatric regional anesthesia has really undergone a profound transformation over the past several decades. It was once viewed as maybe like a technically challenging, really like potentially high risk technique, but it's since evolved into something that's really a cornerstone of modern pediatric anesthesia practice that we use every day. So these 4 converging factors that I personally think have been really the main drivers for improving safety standards is really advances in understanding the anatomy of pediatric patients and anatomy, advances in imaging technology, pharmacology, and really overall safety-focused hospital and institutional practices. So at least let me first start off with the understanding of advances in anatomy. So if we look back, early pediatric regional techniques were really largely extrapolated from adult patients, despite knowing that there are developmental differences. We really now recognize that children are simply not just small adults or tiny humans. There are key differences. So things like a more superficial neuraxis, lower termination of the spinal cord, especially in infants and neonates, and incomplete myelination. These really affect block placement and local anesthetic spread. An improved pediatric anatomical understanding has allowed clinicians to refine their needle depth, landmarks, and expectations of block behavior. And even with these like basic understandings of like foundational anatomy, we still have instances where we're a bit caught off guard or surprised when a block doesn't quite behave what we expect it to. And that's very normal. And I think that's a great way for us to keep expanding our knowledge of pediatric regional anesthesia. But overall, I think the improved understanding reduces the risk of technical failure and neurologic risk. So that's just the first factor. The second factor is the advent of ultrasound imaging. And just like adults, this is a really important advance in pediatric regional anesthesia. Previously, landmark-based and nerve stimulation techniques were quite limited, especially in pediatric patients because of their smaller size, their inability to really communicate, especially under general anesthesia. As we all know, ultrasound has really allowed us to see in real time visualization of nerves, adjacent structures, needle trajectory, and even local anesthetic spread. But this is even more important in pediatric patients because it allows us now to routinely perform blocks under general anesthesia. And what this means is it results in a far less traumatic experience for our pediatric patients. And if we think about it, for everyone involved in the room, adults included. So with ultrasound, it also leads to a higher success rate for blocks, a lower volume of local anesthetic, and really fewer complications such as intravascular injections and pneumothoraces. Imaging has also allowed for us to really adopt more fascial plane blocks, which I think Ronnie will get into later. But I'm going to pull it back to the third factor that has really led to safety in pediatric regional anesthesia, which is advances in pharmacology and dosing strategies. Historically, dosing was really conservative and inconsistent, really driven by the fear that we would have local anesthetic systemic toxicity in kids, also known as LAST. Over time, pharmacokinetic studies have really clarified age-dependent differences in protein binding, in hepatic metabolism, and cardiac sensitivity. This has led to weight-based and age-adjusted maximum dosing guidelines, rather than just simple adult extrapolation. The introduction of longer-acting agents like bupivacaine, levobupivacaine have led to less cardiotoxicity, and then adjuncts like clonidine and dexmedetomidine have further extended analgesia while allowing for lower local anesthetic doses. And then finally, the fourth component of this really long question for safety standards in peds regional anesthesia is really that safety practices in pediatric regional anesthesia have evolved from kind of individual caution to a more system level safeguard. So things like standardized dosing charts, color-coded syringes, ultrasound-guided injections, mandatory aspiration and incremental injection, and even the use of like hydrodissection really allow us to target where our local anesthetic is administered and how much we give. Another component of this is the use of large registry data. And a huge example of this is the Pediatric Regional Anesthesia Network, also known as PRAN. So PRAN demonstrated that complication rates are low when blocks are performed with modern techniques. So with all this combined with improved imaging, dosing precision, really the complications that we've seen in these databases are fairly minor now and mostly transient. So things like catheter dislodgement or incomplete blocks show up way more rather than the more like catastrophic neurologic or cardiovascular collapse. I think this shift really reflects better technology, databases, but also we should give ourselves some credit for it too, in that it also reflects better training, fellowships, documentation, and quality improvements within our individual hospital systems and on a nationwide system. So in conclusion, I think there are four main driving factors for safety within pediatric regional anesthesia. These include advances in anatomical knowledge, really providing that foundation. And then on top of that, imaging, bringing more precision, pharmacology with more larger safety margins, and then evolving standards that have been embedded within our safety culture for routine practice. And with these developments together, they've really transformed pediatric regional anesthesia from what we may occasionally consider as a high-risk adjunct before into something that's more of a core component of safe, effective, and opioid-sparing perioperative care for the children that we take care of every day. So, thanks.
Thanks, Stephanie. That's really good. I know I gave you a very large topic to discuss in 5 minutes, but I think you did a very nice job. I have a next question coming for Rani. Like nowadays, fascial plane block, like any truncal surgery you do, fascial plane block is a part of a multimodal. It's become a fashion in adults and peds as well. And we have come a long way in fascial plane block, and every month there's a block coming up. Do you have any updates on fascial plane block in pediatrics or any innovation that you know and we can share with us, please?
Yeah, thank you for that question, Abhijit, and welcome everybody. It's true that we are moving away from neuraxial blocks in pediatrics in a big way. And a small example for this is the caudal block, which was the most frequently performed block by pediatric anesthesiologists worldwide, has slowly come down. And we have newer blocks that are used. Those are called fascial plane blocks that are used for commonly performed procedures in pediatrics. Like you have inguinal hernia now mostly performed using ilioinguinal blocks, urethroplasties, which were again a common indication for caudal blocks, are now mostly performed under pudendal blocks. These blocks have the advantage of lasting longer than traditional neuraxial blocks, and the advantage of staying away from the neuraxis, which comes with its own set of complications and safety data. So the evolution of fascial plane blocks in pediatrics has pretty much run parallel to the adult world. We've adopted most of the blocks that have been described in the adult world in pediatrics and found uses unique to pediatric practice. As Stephanie pointed out, that ultrasound has been a big catalyst for development of new blocks. To name a few, erector spinae block, which is now found to be a great alternative to thoracic epidurals for thoracotomies and other such procedures for the chest wall. Serratus plane blocks and transversus thoracis muscle plane blocks. In our practice, we use it a lot for placing vagal nerve stimulators, AICDs in patients for chest wall procedures, some thoracotomies, rib fractures, and such like. External oblique intercostal plane block in pediatrics, especially in my practice, it's a great alternative to provide good quality analgesia to kids getting G-tubes, open G-tubes placed. And you know that this patient population is very vulnerable with multiple comorbidities that make opiates kind of restrict the use of opiates in these patients. PENG blocks for both hip and shoulders. We've been using them a lot for hip arthroscopies and shoulder arthroscopies. So the list is long, but I'm going to restrict myself to these new blocks that we've used. And pudendal block is now kind of old. That is, again, one of the commonest fascial plane blocks that we use in pediatric practice. A point that I would like to make here now, that aside from the major gain of discovering new blocks, it is in the improvement of safety and efficacy data that Stephanie also mentioned that can be attributed to ultrasound guidance in fascial plane blocks. We've moved away from the age-old technique of POPs to visualized local anesthetic blooms and unzippering of fascial planes. So this helps in improving block metrics. You have the needle in the correct place. You're opening up the correct plane. So we get a better quality of block. We reduce trauma to adjacent tissues and vascular structures. Going back to the question about dosage, targeted ultrasound guidance has helped decrease minimum anesthetic volumes and minimum required anesthetic concentrations for targeted nerve blocks. However, the difference in fascial plane blocks, because they are volume dependent, that is, a fascial plane blocks requires the local anesthetic to block dispersed nerves or possibly create a pressure head so that the drug volume can travel to a site adjacent to the site of local deposit so that it can provide its or produce its action of anesthesia and analgesia. So, and the volumes can be as high as 0.5 ml per kilo. So we technically cannot reduce the volume in fascial plane blocks as they are volume dependent. So in our practice, we want to be careful, especially as pediatric anesthesiologists. We deal with patients who might range in weight from 5 kilos to 105 kilos. That is imperative to practice weight-based dosing. And I would like to make a push here for using either ideal body weight or corrected body weight for dosing local anesthetics. Lastly, in pediatric practice, age-dependent variations to fascial plane blocks can affect block metrics. For example, in younger children, the connective tissue is known to be looser and more elastic. So this could be advantageous to a pediatric anesthesiologist as we can unzipper fascial planes better. So we get better quality of fascial plane blocks in younger children. Especially this has been demonstrated in erectospiny blocks. However, on the flip side, in very young children, and with the limitation of block needles that are available to us, especially the bevels of the needle can slip in and out of fascial planes, kind of reducing the exactness of the local anesthetic deposits in fascial planes. But this can be forgiving because the thin fascial tissues allow for diffusion into the desired planes. So there is both the yin and yang of doing these blocks in pediatrics. And moving on to fascial plane catheters, I can say that the winds of change are blowing.
Before you go ahead, I just want to add on one comment to that. And
Yeah.
recently in my practice, as you rightly said, the bevel end of the thicker needle, it causes a bit of problem approaching the fascial plane, especially in like few months old kids. It's really difficult. So what I have changed my practice a bit. What I do is I use a single shot needle to open up the space, inject the volume, and then I use a 2He needle to go to the space, because the space is now already filled up with the volume, and I have a lot like it's way easier now to place the catheter and find the space. So this is a bit of change I have done in my practice, and
Yeah, that's
it looks
a
like I'm
great.
very successful. Yeah.
That's a great tip. And what I all practice and I teach my fellows in residence is that you open up a plane and you always advance a needle in the local anesthetic volume, or in that, instead of trying to advance to the corner of the fascial plane. So traveling in a puddle is safer than trying to, open up a fascial plane directly. I'm going to finish up by talking about fascial plane catheters and protocols that are evolving. And very briefly, I can say that the winds of change are blowing. And there is an interest in programmed intermittent bolus regimens for fascial block catheters. Perhaps Stephanie can speak to that later, because her institute, I believe, has moved towards programmed intermittent bolus regimens for all fascial plane catheters. The advantages cited are decreased hourly dosage of local anesthetic. That means it increases safety, and better analgesia, as mechanics of fascial plane blocks require larger volumes and a pressure head to facilitate the flow of local anesthetic to the target area. So think about erectospiny block, where you need for the local to travel to a different target area, or in case of a lumbar plexus block, which is again a fascial plane block in the psoas muscle compartment, where the nerves are widely dispersed, or in a tap block where the nerves are widely dispersed, that once you have a large volume and a pressure head to drive the local anesthetic towards the targets, the quality of block would be better, and you would have better patient satisfaction. So This is where I would conclude about fascial plane blocks and the evolution in pediatric practice.
Hey, thanks a lot, Ronnie. That was really informative. Stephanie, do you want to comment a bit on the program intermittent bolus? Actually, it's a work in progress in my institution. I'm trying to get that for pediatric and adult as well. Maybe in another 6 months or something like that. But yeah, please.
Sure. At Stanford or Lucille Packard Children's Hospital, for a lot of fascial plane blocks, we use a hourly or actually an intermittent bolus, depending on what medication we use, whether it's like chloroquine for our younger children or ropivacaine. We found that it just opens up the space a lot more because a fascial plane block is volume dependent. And then once you have the local anesthetic in that fascial plane, it has a half-life, and so it doesn't need a continuous infusion throughout that entire specified hour or whatever time frame that you're using. And we found kind of better analgesic effectiveness as opposed to the alternative, which might be a continuous or lower dose infusion over that same period of time.
And I will add to this by saying that we recently published studies in population pharmacokinetics in the lumbar plexus region, and we found that you could actually increase your hourly volume times 3, so 0.6 ml per kilo per hour per bolus, and keep the maximum dose to almost 1/3 the hourly infusion rate. That is, you increase the safety metrics by 3-fold.
Amazing. Thanks so much. Okay, and lastly, we have Vipin. There's so much happening in the world of pediatric chronic pain.
So,
cryoablation, neuromodulation. Okay, the stage is yours.
All right. Thank you for having me. Thank you for inviting me, Abhijit. And I want to thank all the speakers in my group as well as the other groups. And I will start with saying,
Vipin, please unmute yourself.
I'm not mute or.
No, I can hear you.
Okay. The rest of you guys, can you hear me, Raj?
Yeah, I can hear you. Some people have had audio issues where they can't hear one or two of the speakers. I'm not sure what's happening, but your audio is coming through.
Okay, it's coming through. Okay.
Yeah.
All right. I was going to answer that. Ed Mariano asked me a question. I've been doing regional anesthesia for the last 10 to 15 years. I love it. I love doing nerve blocks. It's amazing. You can really fix acute pain, but can you fix chronic pain with that? And what excites me now is neuromodulation. You can use neuromodulation to fix acute on chronic pain. And my specialty or my focus has been helping kids with amputation pain. That's, a tragedy that we haven't done a lot with. I've tried single shot blocks. It doesn't work. You need something long acting. I've used catheters. To me, catheters can work, but they have to be at least 5 to 10 days where you see treatment, where you can help the kids with residual pain and phantom pain. But as you know, there's a lot of times when these kids come in, their trauma, their lawnmower accidents, their MVCs, and I hate to say it, this is America. We've had kids, with gun shootings from high schools in the local high schools. So, these are dirty wounds. So you can't keep a peripheral nerve catheter there for a long time. So we had a kid recently where she, came in with strep throat. She crashed onto ECMO because of septic shock. She had all 4 limbs amputated, and it was devastating. And, we tried all our tricks of, stuff, epidurals, single shot blocks, catheters. But this is a kid that, has to be placed on anticoagulation medication. So you couldn't do that. So we tried something that Hesham talked about earlier. We tried a peripheral nerve stimulator for her. And the interesting thing is that she had, the most pain she had was in one limb, and most phantom pain she had in one limb. But when we placed the leads, we used the Sprint device. We placed the leads for 2 months as they, recommend. We just placed the lead in one limb, and, the pain dropped dramatically in that limb, but as well, all 4 limbs. That was the interesting thing that we found. So, her phantom pain went away, her residual pain went away. And even when we took the leads out 2 months later, she continues to have no pain. So she's not on any opiates. She's not on any neuropathic medication. And she's back in full spirit. She's ready to start college. She's getting worked up right now to get prosthesis for her upper limbs and lower limbs. So we restored her quality of life. It's just amazing what you can do with neuromodulation. I mean, these are things that the future holds for us. Try neuromodulation for your acute and chronic pain patients. The next tool that we have is cryoablation. Cryoablation used to be a tool just for the general surgeons and the interventional radiologists, but now you can use that for your amputation patients as well. We have one this coming Monday who also had strep throat, septic shock, and she lost her foot. So we're going to do cryoablation for her leg, and it's worked for our other kids in the past. So there's a lot of new tools coming out that really can change the future of our patients in the long term. So that's two tools. The third tool that I actually was surprised by is that I'm using we get consulted for chronic pain for like sickle cell kids. So we're trying a device for vagal nerve stimulation. And vagal nerve stimulation has been used commercially for migraines, anxiety, but those devices, they just put them like that, and they take them off. The one we're using actually, is just like an EKG lead. It targets the auricular nerve of the vagus nerve. So it actually targets, cranial nerve 10. We have found that my friends at Emory have used it for fibromyalgia. They have used it for rheumatoid arthritis, and it's worked well for them. And we're now trying it for our sickle cell kids, and we've seen, drops in pain scores and opiate usage. So, there's a lot of new tools that we can use from the adult world and bring it to peds. So I encourage everybody to, think about these new tools. I mean, we are great regionalists, and the great thing is these things are, you can place this with ultrasound. You don't need fluoro. You don't need complicated devices. I mean, even cryoablation, there's a portable iovera device that, you can do it at the bedside or, in the OR if you need to, under sedation. So that's my answer to Ed about, what excites me. That is really it. And Hesham, touched on a lot of topics related to peripheral nerve stimulation. That is what we're trying to do in our peds world now.
Thank you so much for all of those information. Those really helpful. I think to make it more interactive, I'll invite questions to our group. Raj and
So thank you guys. And there was a question from our colleague, Jerry Jones. He said, how do you explain to kids the numbness and weakness they will feel after the block?
Can I answer that?
Sure.
Okay, so one way we kind of deal with this is kind of use words that they understand. So I typically explain to my patient and the caregivers, because often these kids go back home, that your maybe, say for example, the foot after a sciatic block, that your leg is going to feel a little sleepy. And as it wakes up, you might feel some tingling. It's like, you have something, zapping your leg. It's very normal. And one thing we have done is moved away from doing concentrated solutions, because that gives a very uncomfortable kind of dense block, almost like a dead body part, which is very difficult to explain to a lot of children. So we typically do blocks with 0.2% or 0.1% so that the transition is gentler. And and when we do catheters for especially our kids who go home, those are teenagers who go home with lumbar plexus catheters or adductor catheters. Again, we've tried to limit our practice to 0.2% because all our patients get general anesthetics. So the transition is not quite as obvious. Does that answer?
If I may add to it too, I think there's a difference between prepping your patient for a single injection or single shot block versus a catheter. And so for a single shot, either one really, I think communication, like Ronnie said, is a huge, it's hugely important both for parents and for kids involved. But I think one aspect that we often maybe underestimate is that even when we're dealing with kids, we often take a very paternalistic approach. But it's if you think back to when you were a child, like things just kind of happen to you, and it feels really like your body's not your body when people are making decisions for it. And I think the same approach for adults, but like kids are the same way. Like it in catheters especially, it's nice to involve a child. Like, hey, how are you feeling? Do you want more? Do you want to like feel your leg or your arm a little bit more than you are right now, or would you rather have it be less painful? And give them that option, so that they can be a little bit more in charge of their bodies and their experience. And I think that is so empowering to them, and that really changes how they can cope with what they're going through, whether it is pain or numbness or any other sensation.
One thing in my institution, what you do is we have involved the child life in a part of a team. So for me, when I finish my first case, then I go and see the patient, talk to them, and come back. But the patient is already here 2 hours prior to the surgery, and all this time they spend with the child life person who plays with them, talks to them in their own language, and that actually helps. And they explain the nerve block a bit more. Okay, this is what is going to happen in a more friendly ways with virtual reality, toys, and different things. So, and before me coming and speaking to them, they're already prepped with the child life, and the families are also prepped by the surgical team when they come to visit the clinic. But the child life actually plays a big role in us in helping preparing the child.
We are actually lucky that we have we have a pain psychologist who comes and talks to the patients, and that really helps them, see how their emotions are doing, and work with them to feel better. So, if you have that resource, that's amazing.
Yeah, I think having child psychologists is really nice, and it's a huge advantage in children's hospitals. But children also go to non-children's hospitals, and so if you don't have those resources, I think just think back to when you were a child yourself, or if you have kids, how would your kid respond to you? And oftentimes we find ourselves being talking at the child, or talking a little bit differently. I think kids can see through it. They know when we're faking it, and so if you're just your genuine self, I think it's a lot more authentic and approachable and believable, really.
Yeah, and co-opting surgeons, because they're the ones who first introduced the block. So having a good surgeon on the team who actually explains the story. And then often these kids come back again and again. So they themselves are advocates. So a lot of my patients tell me, last time it was too dense, or can a block that is more dense? So yes, so I think we should credit them to be individuals, and also have a strong surgical team and child life, as my colleagues pointed out.
Okay. Rakesh, you have a question, or I have another one if you want me to go next.
Just a good audience here.
Yeah, I was my comment to the question about the numbness. I don't take care of young pediatric patients, but in our ambulatory center, like Stephanie said, that we do get teenagers and stuff in a non-traditional pediatric space. And I find that for those teenagers, there's something about the age group between 13 and actually closer to 14, 15 and 24. And it's in young men that if their arm is numb, but it's in a different place than where it fell asleep, they freak out. So if they're getting a shoulder done and it's going to be in a sling, but they fell asleep with their arm by their side, that really messes with their head. So I always try to put their arm in the position that it's going to be at the end of surgery. And for some reason that doesn't create as much psychological dissonance for them, and they don't freak out quite as much. But that's just my own little
No, that's true though. That's a very interesting comment, but we face that every time.
Yeah,
every day.
It's that separation of the where they last remembered it and where they see it with their eyes. It's kind of like when you're on a boat in a cruise ship underneath and you can't see the ocean, and then all of a sudden that makes your inner ear get confused and you get seasick. to me, it seems like it's like a visual seasickness for them, and they get that dissonance. But anyway, my question for you guys again as an adult regional anesthesiologist is, Stephanie, you talked a lot about the safety aspects from the PRAN network and doing general anesthesia blocks under general anesthesia. How much of that is translatable to the adult population? Should we just learn from you guys doing pediatric regional under general anesthesia and take the distress away from a lot of our adult patients and do blocks under general?
That's a really interesting question. So I think I talked about the safety component, but there are also other factors within our practice that we also have to balance. So one downside to doing blocks under general anesthesia is it's time consuming. You have to wait for the patient to be induced and then set up to do your block, and then your surgeon is waiting, and the optics just don't jive as well within the whole perioperative system. And so I would say for an adult practice, which I've also done as well, it's way more efficient to just get the block out of the way and pre-op with a little bit of sedation, with really good communication, and have that patient ready to go to the operating room and have your surgeon be happy, because they're your biggest buy-in. You really can't do your block without your surgical buy-in. And so for us, we do it because the patients and the parents and the surgeons respect that it is safer and a more pleasant experience. But I think the same can be achieved by doing it how most of you guys do it on the adult side, which is to do it beforehand.
To plug the question, so if you have a very anxious adult patient, are you comfortable doing those blocks under GA?
I'm
Because-
100%. Okay, I
Can I answer that
question.
Oh,
sure.
okay.
Vipin, go.
Let me just, I was in private practice. I did peds and adults. So I took care of the patient from all angles, like the anesthesia and the pain. So in my world, it was actually faster to do it while they were under anesthesia, because I'm already putting them to sleep. And it was very safe. I never had an issue. Actually, I got more comfortable doing blocks in adults under anesthesia, and then I translated that to peds.
And, we take care of 100-kilo teenagers. We do thoracic epidurals while they're asleep. And one thing I want to point out, the disadvantage of doing blocks under anesthesia is you have to remind the anesthesiologist at the head of the table not to do a paralytic if you want to use a dual mode, like ultrasound with nerve stimulation, like when you do subgluteal sciatics or you want to do lumbar plexus. So that could be a huge limitation.
Like in my practice, like I practice, Rakesh knows, we have a pediatric hospital within a bigger adult hospital. So I do a bit of adult regional anesthesia as well. And I'm happy to do the block when they sleep. No, like we have breast cancer program. And these patients some of them young breast cancer patients are really devastated, psychologically depressed and all. I'm not going to poke them 3 or 4 times. I'd rather do the block when they sleep. And I have good results from them. Same thing, very often we have hip fracture patients who are in the 80s, 90s, who are already cognitively declined. So we're doing a similar thing. So it'll be difficult for me to poke those patients awake because there's so much of cognitive decline and moving a lot. So we put them to sleep and do the block. So I'm happy with my knowledge from pediatric to translate that in adults and do it unless it's a surgical block that is needed.
So for us, we have a checklist modification. We always, if there's a regional involved, the checklist defaults to, do you want to do paralytic? So the nurse asks that even before we induce. So the team is prepped, and we actually, again, page the anesthesia team to let them know again. So there's a double and a triple check to remind them, hey, no paralytic, you can intubate with maybe large dose propofol or remifentanil or succinylcholine.
Yeah, my shorthand for this is that if I'm dealing with an adult, if it's a fascial plain block, I'll do it in under general anesthesia anytime. That's a chip shot. But if it's a peripheral nerve block, if the adult is going to act like a child, then they'll get a pediatric regional, which is under general anesthesia. So that's the simple version of how I interpret the PRAN network. I just take that information and carry it over. And if they can
It's
be,
probably safe.
and even if, and I've had teenagers that can act like adults, and then I'll do it awake. I'll do the blocks while they're awake under sedation, and I'll usually just ask them at that point. So I've had it both ways.
Yeah.
Well, I want to thank you guys. We have had, this has been a great panel. I really appreciate all of your guys' insight, incredible knowledge. Pediatric Regional, it's this conversation I've been hearing about for the last decade, and it's just accelerated over the last decade. And it's exciting to see that children are having better options for pain management, both chronic and acute pain, and for perioperative care. So you guys are really leading the charge on that. I really appreciate all of you guys being here as part of the World Day of Regional Anesthesia and contributing this. Thank you so much.
Thank you all for inviting us.
Fantastic job organizing as well and inviting us.
Yeah.
Well, thank you guys. Have a great day.
Bye.
Thank you, team.
Bye.
Well, Rakesh, we have had quite the day for World Day of Regional Anesthesia. This has been great. What'd you think? You were intimidated about being part of this long live stream.
And also the diverse group of speakers and the diverse topics. It's like covering anywhere from neuromodulation to safety in regional anesthesia. It's a very rewarding experience.
Yeah, I think that the lesson we learned in here is that all we did was scrape the surface of all of these topics, and both our speakers, probably our audience, I know us, were enthusiastic to dive deeper into each one of them, and we just didn't have the time or the energy to get through an hour-long discussion on every one of these topics. And like I said earlier, that's why you go to the conferences, you go and meet these people in person and really get to enjoy that passionate discussion as deep as you want to at that point.
Yeah, this is like a snippet to the main meeting if people want to engage more in in-person discussion.
And I encourage you guys. So ASRA has our meetings, the spring meeting. I'm going to put these up here just to kind of remind people as we wrap up. We have our spring meeting coming up in Phoenix. A great place to continue this conversation. Registrations are open. Go and join us. We'll be there, and I can't wait to talk to you guys in person. The chronic pain side, these topics are blending. There's skills from chronic pain that are applicable to acute pain. There's skills in acute pain applicable to chronic pain. So this meeting in Tampa will have a lot to offer people. And for those of you guys who are in other places, you want to go to the European Society meeting. That's going to be in Lisbon, Portugal this September. I'm going to have the opportunity to go there in Lisbon and be at the ASRA meeting. So hopefully I can, if you're at that meeting, come say hi there. I'd love to talk to you more at that meeting as well. And then just as a reminder, our society has so much to offer. Become a member. The journal is fantastic. RAPM is constantly full of new and amazing content. You heard Tony Machi talk about the ASRA Pain Medicine News, consistently high quality content in the ASRA Pain Medicine News. Become a member. You can read this. This archive is fantastic. We have special interest groups, so many special interest groups within our society where you can actually get your voice heard in a niche group of people that are particularly interested in the topic that you're interested in. And then that content elevates to the society as a whole. We have a career center. So if you're looking to get a job, there's opportunities there. And then of course, join us on social media. Lots of social media channels for our society. Stay involved in the conversation, get engaged with the people in the society, the faculty, the leaders, the residents, the fellows. That network effect that Jody Lang talked about, the relationships, really important. So like I said, become a member of the society, asra.com/benefits to learn all about membership and be part of the conversation. And then we want to thank ASRA for the inspiration for the World Day of Regional Anesthesia. This wouldn't happen without their leadership. It's the third year in a row. I have no doubt that we'll be back for the fourth year, and we have so much more amazing content for everybody next year. So Rakesh, thank you for joining me on this journey. It's been a pleasure.
Likewise. Thank you so much. And it's been a learning experience.
Everybody, thank you for joining us. Those of you who stayed on for the whole day, you can watch this again on YouTube. Just rewind and watch the section that you're interested in. Share it with your friends. Share the link on YouTube. Share the ASRA page. You can find it lots of different ways. And we look forward to talking to you guys in person. Have a wonderful day.
Bye.
Thank you.